So now we will begin our sessions. Let me briefly tell you that we have kept this symposium to cover every aspect of HCC, right from what is the epidemiology of HCC and what are the recent therapies, including radiotherapy, systemic therapy, and surgical therapy, loco-regional therapy. So we have tried to cover all. So to begin with, for the first session, I would like to invite Dr. Bhavesh Thakkar as chairperson and Dr. Sameer Paghadar and Dr. Pathik Parekh to come to the dais. And the first topic would be covered by Dr. Sudhanshu Patwari. So chairpersons and moderators can introduce our speaker, Dr. Sudhanshu Patwari.
I think Sudhanshu sir, everybody knows. We don't need any introduction for Sudhanshu sir. Just to let us know the most grounded and the most human gastroenterologist of Ahmedabad. This is how I would recognize him.
Thank you, Pathik, actually, for very nice words. And good afternoon, friends. Actually, when Ashish told me about the epidemiology of HCC in context to India, I thought it's a very simple thing. And when I started looking for literature, then I realized that it is the most difficult thing. And so to begin with, can I have the next, please? Actually, we don't have. I think this is all right. Yeah. So, to cover the HCC, it is the sixth most common malignancy in the world, and surprisingly, it is the third largest cause of cancer-related deaths. So, it has a very high mortality rate. In few decades, we have witnessed the emergence of non-viral causes of HCC. Most common is the non-alcoholic fatty liver disease and NASH, with or without cirrhosis. About 3 to 15% of the obese patients with NASH progress to cirrhosis, and about 4 to 27% of the NASH-related cirrhosis, they will progress to HCC. So I think these figures are very frightening. And it is now known that HCC can develop de novo in patient with NASH without presence of cirrhosis or significant fibrosis. This is very frightening. The yearly cumulative incidence of NASH HCC is low, not very high, 2.6, as compared to the 4 other viral and alcohol related etiology, which is about 4%. To go to the natural history of NASH, most of the NASH it is an isolated fatty liver or fatty liver with mild fibrosis, and about 20% of them will develop into steatohepatitis, ultimately cirrhosis, and few of them will develop HCC. There are some risk factors also that we will see in subsequent discussion. Now, who will develop HCC? There are some predisposing or precipitating factors like endocrine or hyperinsulinemia, genetic predisposition, inflammatory cytokines, which will cause altered immune system, and the metabolic stress. There are few international studies, quite a few, But these are the studies they have studied very prospectively. This is very good studies, but over the about 10 or 15 years, about 10% of the NASH cirrhosis, they have developed HCC. So this is quite a high number. Now, when I started looking at our literature, that is in context to India, now way back in 2013, there is one article by Bhattacharya in the Chinese Clinical Oncology, which suggests that about 10% of the NAFLD HCC, they will go for NAFLD HCC, means 10% of them will go for HCC. There was another article by Acharya in Journal of Clinical and Experimental Hepatology, again in 2014. It was a review article, but again at that time the commonest causes of HCC was viral and alcohol, and very few of them were related to the NAFLD. In 2019, as Dr. Ashish suggested, there was a Puri 2 meeting about the HCC guidelines, and they have suggested metabolic syndrome as one of the main etiologies for development of HCC. And latest is published in 2023 Indian Journal of Gastroenterology, and this is a very good actually article, and it was an editorial also, but article, it is good that all the centers of Kerala, they have collected the data of HCC, and then it was presented in Indian Journal of Gastroenterology. The NAFLD account to about 35%, way more than hepatitis B and hepatitis C and alcohol. And non-cirrhotic HCC, that is the NASH without cirrhosis, about 9 to 20% account for the non-cirrhotic HCC. And in I asked Dr. Hitesh, actually they have done 33 liver transplant in last about 10 years, and 8 of them are NAFLD related. So that is also about 1/3 of the patient, 25% are because of the fatty liver disease. Now, as we know, the cirrhosis itself is a risk factor for development of HCC, but there are few other patients with high incidence of HCC. They are male, means age more than 60, smokers, diabetic with high SGPT, and insulin users. They have high incidence of developing HCC. So even without development of cirrhosis, they can go for HCC. The experience of the world over also suggests that along with the viral and alcohol etiology, there are more and more increasing number of patients of HCC related to fatty liver disease. And there is a graph shows that over last 10 years, from 2010 to 2019, the incidence of hepatitis B and hepatitis C is reducing, but fatty liver related mortality, means development of HCC and mortality remains the same. So to learn, what we have learned is that in 2019, because the last available is 2019 probably, estimated mortality world over is 485,000 deaths related to HCC. In last 10 years, the liver cancer is increasing, especially in America, because the data is available from USA. NASH is the fastest growing cause of age-adjusted liver cancer death globally, and the liver cancer deaths from hepatitis B and C is declining. The NASH liver disease is becoming a leading cause of development of HCC, especially with metabolic syndrome. And obesity, that is the BMI more than 30, doubles the risk of HCC, and the morbidity is also more. The BMI more than 35 kg per meter square quadruples the risk of HCC. So the more the obesity, insulin resistance, the more chances of development of HCC. And what we have learned from this experience of epidemiology is that there has to be a national registry properly maintained for HCC. The subject of nutrition, exercise, and the bad effects of alcohol and smoking should be taught separately as a subject in the primary schools. More aggressive strategies to prevent hepatitis B and C. This is very important because it is declining, but even then we have to take care of the B and C virus. This is what I always say, that menu card approach to each diet item and exercise should be promoted actually. Whenever you eat something, you should know that what you are eating is 500 calories, 200 calories. Because then you become more conscious about the diet, and even the exercise also. Everyone should know that what exercise, how many calories are spent in what exercise. Because unless everybody says that I walk for 30 minutes a day, but then that stroll will not give you any advantage. So how to walk, what speed you have to walk, and how much to walk, that should be really known to everybody. It's not simple walking, climbing stairs or whatever it is, but everybody should know about this. And the screening strategy for HCC for early diagnosis, especially for NASH related chronic liver disease, should be promoted. And it should be known to all the healthcare persons, because most of the time it is our experience that patients are asymptomatic. Most of the family physicians, even general MD physicians, they will say that this is nothing actually, don't worry about it, you don't have anything. So that not to worry at the end of 5 or 10 years will lead to cirrhosis or HCC. And HCCs, when they are diagnosed in NASH patients, they are usually large, unresectable, and the prognosis is bad. So we have to have joint efforts to prevent the NASH, NASH-related chronic liver disease, and HCC. Thank you.
Any questions from?
So that was an excellent presentation. So as we know that NASH-related HCC is increasing, and then obesity and diabetes are important risk factors. So do you think in future we would the present guidelines to screen HCC is only for cirrhotic, even in INASL guidelines. So do you think in future we would start having guidelines for screening NASH patients as well as, or maybe obese patients or those having NASH with fibrosis?
I think we must have guideline for the NASH with fibrosis actually, because 20% of the HCC, which are NASH related HCC, they are not having cirrhosis. So this is a very large number actually. So we have to screen those 20% also. So I think we should have a guideline for screening, and our screening is a little simpler actually. I tell you, we go for alpha fetoprotein along with LFT and sonography. So I think it is not very expensive also, but I think screening should be done for these patients.
It's about 30% of the India's population suffer from NAFLD, so getting them screened every 6 months would be, how justifiable would it be? We need to actually number needed to treat for that or number needed to screen for these things. Instead, if what I would say that all diabetologists, all physicians usually get USG Doppler, renal Doppler for all the diabetic patients on a regular basis. but they never look at the liver. They only look at the kidneys. So I think rather than giving or sending all patients for screening, we can actually formulate a guidelines for diabetologists and tell them that, you know, you are already looking at the kidneys, please look at the liver also. That would pick up, because most of our patients are 50% are diabetic. So at least that would take care of 50%.
No, I agree, but see, I tell you, the 30% of the population is having a fatty liver disease, out of which 20% are having NASH, out of which maybe 10% are having with significant fibrosis. I think we should screen patients with significant fibrosis. You can't screen the whole population. Like screening colonoscopy is not possible in our country. The screening all fatty liver disease is not possible, I think, for any country. Because we have an incidence of 26 actually, about 26. USA it is 32. Now even with that population also 32% they cannot screen. But with significant fibrosis, yes.
Yeah, I think I would agree with you also, because most of diabetes, the endocrinologists or those physicians managing diabetes, they are hardly bothered about the liver. So they are looking at retinopathy and nephropathy, but I think we need to increase their awareness too, that diabetes is a significant risk factors, and at least liver fibrosis should be screened in them. And then from then onwards, all those having significant fibrosis can be subjected to HCC screening.
FIB4 scoring for all patients with diabetes.
Diabetes, yeah. FIB4 can be done.
Yeah, yeah, yeah. So FIB4 can be done, or fibroscan if available, that can be done. So that.
But I think diabetologists, they have a very eklavya eye, actually Arjun. They will not see the carotid also. Most of them, yes. They will look for the renal, they will look for the eyes, it's retina, but not carotid. So that's why awareness is very important, actually.
Thank you, sir. Thank you, chairpersons and moderators. For the next session, which I would be presenting, the INASL HCC guidelines, I would like to invite Dr. Jignesh Patel, Dr. Jatin Patel, Dr. Ruchir, Dr. Rushabh Rawal as chairperson, and Dr. Viraj as the moderator. So these are the introduction. Dr. Jignesh Patel is at HCG Hospital. Dr. Jatin Patel, Ahmedabad Gastro Associates. Rushabh Patel, I'm sorry, previous. Previous introduction. Rushabh Patel is at Starlit Cancer Center. And next, Dr. Viraj is medical oncologist attached to Health One Hospital, Ahmedabad. So should I begin?
Yes. So just for the audience, I've recently joined Shelby Hospitals 4 days ago.
Okay.
So yes, it's a very interesting topic we have today, and I think so we are eager to listen to your talk.
Okay.
Please go
Okay.
ahead, sir.
Thank you. Slides. So I'll be presenting the INASL guidelines, what is new. So as I mentioned before, INASL had published the first guidelines in 2014 and then 2019, and this one, which is just published about 2 months ago, is 2023. In between, INASL and ASLDs and other societies like NCCN, Japan, Korean societies, many of the societies have been publishing their guidelines. But in India, we generally follow INASL as well as ASLD and the INASL guideline as well as the NCCN guidelines. So this is the what we published in August. It is published in Journal of Clinical and Experimental Hepatology. The first guidelines which were published in 2013, the meeting was held at Puri. So from then onwards, we started calling these as Puri guidelines, because Puri 1, Puri 2, and now this one is Puri 3. So the second one was, the meeting was held in 2018, and this meeting was held in 2022. So what is new in the INASL 2023 guidelines? So this time we have focused mainly on intermediate and advanced HCC. In the previous version, we had covered the entire HCC, including the diagnosis part and the prognosis and all that. But this time we purposefully left out the diagnosis, because in last 4 or 5 years, at least in the diagnosis, there's nothing has changed much, but there's a lot of development which has taken place in management of intermediate and advanced HCC. So we covered this part entirely in this session, and we also divide the new HCC staging system, which we called as INASL BCLC staging system, so which is more in tune with the current practices in India, which is a modification of BCLC staging, which I'll briefly discuss. And we have also focused on combination therapies, because now more and more evidence is indicating that combining systemic therapy with local regional therapy, or ablation and resection, the outcomes are much better than giving these therapies on alone basis. And then there's a recent advancement in the role of SBRT. So we have introduced SBRT also in the algorithm because of the excellent result and much more affordable than other costlier therapy like TARE. So what is new in the staging? So we all are aware with the BCLC staging, which we are very familiar, and there's been many additions of BCLC staging. So this BCLC, the most recent, was published in 2022. The BCLC staging divides HCC into 5 stages. Stage 0, which is very early stage, stage A, then B, C, and D. D is the terminal stage. So we have, in our INASL BCLC staging, we have adopted the same staging, but now we have also subdivided into many groups within each stage. So what were the shortcomings of BCLC staging? So in the BCLC staging, there was no mention of combination treatment. For example, combination of TACE with systemic therapy, ablation with systemic therapy, TACE and SBRT, etc. Those combination was not mentioned. So you would either receive ablation, resection, or systemic therapy or TACE depending on your stage. The TARE was missing from the algorithm. As you can see in this is from the BCLC staging, there was no mention of the TARE. So they do mention TACE, but they do not mention TARE. And TARE, as we know, is a good modality, although expensive. In the BCLC staging, the down staging was also not incorporated in the algorithm, although they mentioned it in their text. But it was not clear which patient should undergo downstaging prior to liver transplantation. And also BCLC being developed in mainly Western countries, so it was not very well suited for LDLT setting, because most of the liver transplantations are there, disease donor. So it was not very well suited for LDLT. Also in stage C, the BCLC stage C, they have clubbed together the portal vein tumor thrombosis as well as extrahepatic metastasis. So they club together and they call it BCLC stage C, and for them they have recommended a systemic therapy. But we felt and that the prognosis of patients with portal vein tumor thrombosis is better and different from those having extrahepatic metastasis. So this was another shortcoming. And also in the BCLC stage D patient, that means terminal stage, if they have a small tumor, the option of liver transplantation was not given. So if the patient belonged to BCLC stage D, they just recommended best supportive care, and there was no option of liver transplantation. Also, as I mentioned, there was no mention of SBRT in the entire algorithm of BCLC staging. And the liver's function assessment, as we all know that BCLC staging incorporates three things. One is tumor stage, the other is liver function, and the third is performance stage. But for liver's function stage, they mentioned that you can do either LB score, or you can do Child-Pugh score, or do MELD score. So they gave all three options. So this would lead to increased heterogeneity in staging. So if one center is using MELD score to stage their patient, the other center is using Child-Pugh, then these patients would not be very comparable. So this liver function assessment was not uniform. So taking these shortcomings into consideration, we have modified the BCLC staging, and we have called it as INASL modification of BCLC staging. So the background remains same. So we still have the five groups: stage, very early stage, 0, early stage, intermediate stage, advanced stage, and terminal stage. And then we have further subdivided into stage A1, A2, stage B1, B2, B3, stage C1, C2, and again D1 and D2. So how we have incorporated these changes. So this was the BCLC staging. There was no incorporation of the liver transplant criteria. So there was no mention of any liver transplant criteria. Although they say that single tumor or less than 3 centimeter, or less than 3 nodules, all less than 3 centimeter, should undergo transplant. But they do not mention the exact criteria. So what we have done in the INASL BCLC staging, we have called it that in the early stage, the patients, So in the early stage, if the patient belongs to stage A, then the patient would be having within Milan criteria. But if the patient is having any extended liver transplantation criteria, then he would be considered in stage B. So we have mentioned, all liver transplant criteria like UCSF and beyond would be all considered in stage B. So we have explicitly mentioned the liver transplant criteria. And when should we do downstaging? As we mentioned that in the BCLC staging, there was no mention when to do downstaging. But here we have clearly said that if the patient comes within Milan criteria, that means stage A, he can undergo upfront liver transplantation. If he comes with stage UCSF, who meets the UCSF criteria, then he will be called as stage B1. Again, he would undergo upfront liver transplantation. And any patient who comes beyond UCSF criteria, then these patients should preferably be downstaged before taking up for transplantation. And if the transplantation is not available, we have also mentioned that these patients would go to loco-regional therapy, that is TACE and TARE. So we have this system when to do downstaging and when should we switch to the loco-regional therapy when liver transplantation is not available. And we all know that there's a good benefit of downstaging, and this study which I'll also present briefly later on from Medanta group, where they have shown that patients who come beyond UCSF criteria, these are high-risk group, and it is better to do downstaging before taking them for transplantation. When should we do TARE? So it was tear was not mentioned in the BCLC criteria staging system. So here in the INASL BCLC staging, we have given the option of TACE or tear for all the patients who come in stage B, that means intermediate stage. So you can do either TACE or tear if tear is affordable. And all patients who have diffuse or infiltrative HCC, that is stage B3, the tear would be better. And also for patients with portal vein tumor thrombosis, also tear would be better. So comparing tear versus TACE, there are now many studies that with tear, the survival, overall survival as well as recurrence-free survival is much better. Now also BCLC stage C, like I mentioned, that patients with portal vein tumor thrombosis and extrahepatic metastasis were clubbed together, but we have subdivided them into stage C, C1, that all those patients who are having only portal vein tumor thrombosis but not extrahepatic metastasis, and these patients would benefit from tear as well as SBRT, and in very selected patients even resection can be done. And for those patients who have extrahepatic metastasis, obviously these patients would directly go to systemic therapy. And can we do liver transplantation in end stage patients, that means stage D patients? The BCLC say that you cannot, you just have to give best supportive care. But in INASL BCLC staging, we have again subdivided these patients into stage D1 and D2. So D2 are those patients who have a small tumor burden. So their tumor burden is within UCSF criteria. And so these patients can be taken up for transplantation, and there's evidence there to show that these patients behave as well as those patients who are transplanted without HCC. And those patients who have tumor beyond any transplant criteria would obviously be receiving best supportive care. And so with this division, we have given transplant option also to the INASL BCLC D staging. And there's now many studies which have come up which have shown that if the tumor burden is small but the patient is having decompensated liver cirrhosis, they would do well with liver transplantation. Coming to the role of combination therapy, now we have increasingly seeing that patients with combination therapy, for example, if we give loco-regional therapy and then we add immunotherapy subsequently, these patients have much more better survival. And very recently, just 1 week to 10 days ago, we again had a very good, excellent study on using immunotherapy for those patients who have just now undergone resection or ablation. So even in earlier stages, combining adjuvant systemic therapy leads to better survival. So many other studies like combining lenvatinib in those patients who are undergoing TACE, they have better survival. And then there's perioperative immunotherapy, like I mentioned. These patients also do well if we combine systemic therapy. So we have incorporated combination therapy in our staging system. So in the stage B or C, first you'll give loco-regional therapy, and then you'll follow up with systemic therapy for better response. And this was not there in the BCLC staging system. What is the role of SBRT? So we are in last about 4-5 years, we are seeing increasing role of SBRT, which is much more affordable treatment option, especially if the tumor is small or if the tumor is in the portal vein tumor thrombosis. SBRT leads to good local control and it increases overall survival with minimal toxicity. So we have incorporated SBRT in our staging system. So if in the early stage, that means intermediate stage, stage B, along with TACE and tear, SBRT can be added. And also, if the patient is having portal vein tumor thrombosis, SBRT has a definite role prior to giving systemic therapy. So to summarize, INASL HCC guidelines have been just published, and I urge all of you to use them. These are updated and it is suitable for Indian setting. It is available in the JCH website. The INASL BCLC staging system is a significant improvement over the standard BCLC system, and I encourage all of you to use this staging system for our Indian patients. So you can click a picture of this INASL BCLC staging system, and this is available to download from the JCH website, and very soon it will also be available in the PubMed. So you can download the entire Puri 3 guidelines from using this QR code. So with this, I would like to thank you for your patient hearing, and I would be happy to take any questions.
Great talk, sir. Any questions in the house before I have a couple? Go ahead, please.
What do you feel about like we have on we are giving RFA to patients in the stage B. So do you feel any role of US guided RFA, and if we are if there is role, where you will put it along with this treatment in this staging system,
So,
like radio frequency ablation, US guided, if at all.
So ablation in general, whether by any means, for example, previously we used in better advancement, now we are doing microwave ablation. Now recently US guided ablation, which has come and which is would be under the domain of gastroenterologist and our endoscopists. So this is an upcoming modality, but we would need more data, and it will be better suited for very small tumor like
Peripheral lesions.
peripheral lesions for whom I mean, which can be done under a gastroenterologist supervision, but it would be better only for 2 to 3 centimeter lesions. But beyond that, I think intervention radiology would be taken. And we would need more data, comparative data with the intervention radiology.
Sir, one question I had. I know you didn't include biopsy and diagnosis part in this update, but let me come to the therapeutic window first here. I like this strategy, categorizing B into B1, 2, 3. The question I had is B3 more likely behaves like C.
Yes.
Would it, what is your thought in using systemic therapy first, and then if they do well, do you target them with loco-regional therapy? Point 1. And point 2, in C1, where I completely agree with you that with MVI, microvascular invasion, they are different than extrahepatic disease. But again in them, giving them SBRT and then doing systemic therapy, and then if they do well, seeing the biology, then you target the liver lesion with either TACE or TARE. So what is your thought in flipping the sequence?
Yeah, flipping the sequence is possible. Actually, what we mentioned in the guidelines was that you use combination therapy. Whether you start with the systemic therapy and then go on to do the loco-regional therapy, that can be done, and in the guidelines there is an option for that also. But in the algorithm, although we have mentioned that, for example, in the B3 also, TARE we have written, and we have put in the bracket if feasible. So they could directly go to systemic therapy. And also there is a guideline, in the guidelines we have mentioned that with the systemic therapy or with any therapy, if the tumor improves or the patient responds, then we can restage these patients, and then they subsequently go into the loco-regional therapy, or even they can be suitably downstage to even undergo transplant.
Correct.
So the
So that's more
sequencing,
plausible,
yeah,
right?
the sequencing
Because
can be.
we see people practicing this by the book, you know, with a large tumor, with microvascular invasion. The IR seems to go first, and it's always a quarrel between IR and a medical oncologist.
So yeah, I can see from your, but actually prior to this immunotherapy, only that when TKI were there, so with immunotherapy, we are very happy to see that even in about 5 to 10% patients, there's complete response, which was unheard before. So some patients can, even entire HCC can vanish. So that is the, and now more and more immunotherapeutic approaches are coming, and so these, the sequence can be changed, But the
Perhaps in the
essential
next
idea
Puri
remains
meeting.
that you would embark on combination therapy rather than the single
So
type.
hopefully in next Puri meeting, this
Yeah,
will be
we can.
Great. Last question before we end this. I know diagnosis was not part of this update, but like since the immunotherapy, I have started biopsying all patients, even though the radiologist says this is classic HCC. And the reasons are twofold. One is, of course, couple of years back, we had a UK audit which said that about 10%, even though when a radiologist is pretty sure, the diagnosis was mixed, point one. And point two, we know immunotherapy is not great with NASH-related HCC. And we want to do more and more molecular analysis, right? So you think that would creep up in your next update?
So in this update, although we did not include the biopsy, but there was an entire section on prognostic markers for HCC. So there we did discuss the biopsy, the histological aspect also. And as you mentioned that you are now starting doing biopsy on all your patients. So these patients are obviously what patients you see are those are all advanced patients. So there's no inhibition in doing biopsies in them, and at least you are sure with the diagnosis, because even I have seen many patients whom we were thinking that it is HCC, but it was a mixed intrahepatic cholangiocarcinoma or cholangio and HCC combination was there. In them, obviously, the therapy, systemic therapy would change. That is one aspect. And second, with biopsy, then we can also do certain like PD-L1 expression also can be done, although that has not come in the guidelines as such, but that can at least give some idea which patients would respond better to immunotherapy. So I would completely agree. And again, like I said before, that we need to now rapidly change the guidelines every 2 to 3 years, because there's so much advancements which are coming recently.
Great. Any other questions from the house? Then we'll wrap up this session, sir.
Yeah.
Thank you very much, sir, for your talk.
Thank you for the moderation and the chair. I thank you all. So coming to the next session, that is on the use of SBRT, a new kid on the block. I would like to invite the chairpersons, Dr. Kaushal Vyas, Dr. Hardik Parekh, Dr. Kavian Shah, Dr. Malhar Patel, and moderator Dr. Jigna Bhattacharya to come on the stage. And the speaker would be Dr. Samir. I would ask my chairpersons and moderators to introduce the speaker.
I welcome Dr. Samir Batham, who is a senior radiation oncologist at HCG Cancer Center. And I think we would love to hear him about SBRT, because he is very expert in his subject.
Thank you, madam, for the kind introduction. At the outset, I'd like to thank INASL, Hitesh Chavda sir and Ashish sir for giving me this opportunity. So I'll be talking of use of SBRT for HCC, a new kid on the block. So as we know that when we talk about liver cancers, the HCC is the most common one. Almost 80% of the liver tumors are HCC. The incidence, we know, I will not be repeating it again, that the incidence is increasing day by day globally as well as in India. And there are many staging systems. Of course, most commonly used is the BCLC. And I was very impressed to see the INASL. I was not aware about it, but definitely this is more relevant for our patients, and I will keep in mind when the next patient I will see in my clinic, definitely that would be based on INASL BCLC. So basically BCLC takes into account the tumor size, tumor burden, liver functions, performance status, and accordingly they classify patients into very early, intermediate, advanced, and terminal stages. Of course, they have certain treatment recommendations which were published last year only. When we talk about radiation, in this whole matrix, we'll see that if you grossly look at the picture, radiation has a role in almost every step. Even in early diseases, when the disease, even patients who have early disease and they are not candidate for transplant, there we can use radiation. Patients who are candidate for transplant, radiation can be used as bridging. In intermediate stages, again, definitive radiation can be used, and in advanced and metastatic disease, again, radiation has a role in palliation of symptoms sometimes. The standard NCCN guideline, they also recommend that even for resectable patients, if surgery, although which is the preferred option, if this is not feasible, somehow radiation can be tried. For unresectable diseases, again, radiation can be given, and for patients who are unresectable because of the comorbidities. So there are two criteria, whether if it is unresectable because of the disease, or if it is unresectable because of the comorbidities and performance status. Again, radiation can be tried in these patients. And SBRT has recently gained more popularities. Even NCCN clearly mentions about using SBRT. They also recommend the doses and fractionation which can be offered to patients of HCC. So what is SBRT? So SBRT, as per American College of Radiology and Astro, they defined as an external beam radiation therapy method which is used to very precisely deliver a high dose of radiation to an extracranial target within the body using either single or small number of fractions. So when we consider, when we see a patient in our clinic, these are the parameters which we keep in our mind: the patient parameters, age, comorbid conditions, performance status, liver disease etiology, tumor characteristics, histological data, liver functions, the associated complications, portal hypertensions, what is the status of transplant, and the financial constraints, of course. So these are the things which we keep in mind when we assess a patient for SBRT. Again, as Sir showed in his slide, SBRT is in fact not very new. There are many published studies, most of them, of course, phase 1 and phase 2. They are, again, I'm presenting few of the slides which have used more than 20 patients. Most of the studies of SBRT are done in child A only, and there are some data where we have used in child B, but for child C, we do not have that strong data which support use of SBRT. The good local control and the acceptable toxicity is what makes SBRT an ideal option in these patients. So as a bridge therapy, this has probably a very promising role, of course, along with the other options like TACE and TARE. And probably most of the previous studies, they were focused on comparing TACE versus TARE versus RFA versus SBRT. I guess now we should be focusing more about combining, as Sir mentioned. In fact, nowadays more and more studies are going on in combination of these therapies. So basically, patients who are fit for transplant, they often have a long waiting, and bridge therapy prevents disease progression. The good number of studies, few of them mentioned here, the study by MSKCC, where SBRT was used as a bridge therapy. The 3-year OS and DFS 77 and 74% when SBRT was used. As per the studies by St. Drosy, again, most of the patients, they received SBRT. Many of them, they received SBRT after TACE and RFA, and again, they found that with SBRT, there was significant reduction in AFP, and the tumor size also regressed significantly. So when we talk about early stage inoperable disease, we know we have some set criteria for resection, but unfortunately, many of the patients, they do not come to our OPDs when they are resectable, And for those, sometimes chemotherapy, whatever literature we have, it somehow has not shown any extra promising result, and has not shown any magical response in terms of OS or PFS. So the published trials, the way they have established similar outcome with SBRT as compared to other modalities, higher local control for larger tumors, good response even after multiple line of failures have been seen, and I will show one of these study in my subsequent slides. For intermediate stage disease, when the tumor is a bit large, although there are new updates which suggest that these patients should be considered for transplant, the other options include RFA, TACE, SBRT, and of course combination, which I would prefer. The grade 3 toxicities, when we compare as per some literature with TACE and TARE, this was seen in up to 10 to 80% of the patients, while with SBRT this was seen in 5 to 30% of the patients. One of the Korean study which was done in patients who had received multiple TACE in the past, they also showed with SBRT the local control rate of almost 94%. In advanced stages, again, although these patients, when they have microscopic vascular extension, extrahepatic extension, most of these patients are not an ideal candidate for surgical resection, and especially when they have decompensated liver cirrhosis or portal hypertension, they do not have that. They usually don't do well with either surgery. In fact, most of them are not candidates for surgery and with systemic therapy. Although now we have atezo and bev, more and more targeted and newer immunotherapies are replacing the conventional chemotherapies, and which are showing promising results. But even radiation has been tried, not SBRT in the very advanced settings, but radiation has shown recanalization of vessels in almost 33% of the patients in one of the study, and a local control of more than 90% in these patients. Not going to this. So when we talk about the inclusion or exclusion criteria for SBRT, first and the most important is whether the patient is fit for immobilization, because there are certain steps of radiation or SBRT, which again I will be talking about in my subsequent slides. But if you do not have a setup where you can immobilize your patient properly, you cannot control the motions, probably SBRT should not be tried. There are certain tumor characteristics. Nowadays, almost, this was an old concept of treating 1 centimeter, 5 centimeter, whatever. Now the new concept is you should be able to spare a normal healthy liver. 700 cc of healthy liver, if you can spare from radiation, you can practically treat almost any HCC. The other thing is the location. It should not be adherent to, or it should not be invading any critical structures, the bowel, rib, chest wall. If the patient fulfill this criteria, then the patient can be taken for SBRT. The combination studies which we were talking about, one of them was by Jacob et al., which was published in 2015. The patients who received TACE plus SBRT, the local recurrence were significantly less in these patients, and the median OS was also much better in the patients who received combination of TACE and SBRT. Another study where TACE SBRT was compared with SBRT alone, and they again find that the radiological response with combination was better, the PFS, OS, and the time to progression. All these parameters were favoring a combination of both versus SBRT alone. So when we talk about SBRT versus RFA, this is an old retrospective study where they compared SBRT and RFA. And, these were the patient characteristics. I would just go to the bottom line. What they found that when we used SBRT, the OS and the toxicities were almost comparable, and they concluded that both RFA and SBRT are effective local treatment option for inoperable HCC, and SBRT appears to be reasonable first-line treatment of inoperable larger HCC. In this study only, they found that tumor more than 2 centimeter, usually these are the patients who can do better with SBRT than RFA. but as I said, these were retrospective. Again, we do not have, in fact, we do not have any large randomized prospective studies which have compared SBRT versus RFA or TACE. Of course, there are some ongoing studies. We'll be having the results of those studies maybe in next 4 or 5 years. But as of now, we do not have any large or strong evidences which, says that SBRT or one modality is significantly better than other. But these are the studies, whatever published data we have, it suggests that SBRT is definitely non-inferior to other local therapies. So this was a randomized trial, which the abstract was presented recently in ESCO GI, the RTOG 1112 trial, which compared SBRT with sorafenib versus sorafenib alone, and what they did basically, randomization was 1:1. Over 100 patients, they were randomized. The first arm received sorafenib alone, 400 mg BD. The next arm, the other arm, received SBRT in the doses of 27.5 to 50 gray in 5 fractions. And this was followed by sorafenib. So if you'll see that most of the patients were BCLCC, 74% had macrovascular invasion, and these were quite large tumors. In fact, even in SBRT, the maximum dimension was 6.7 centimeter. In fact, they treated even larger tumor in this study. And what they found that the toxicities were all comparable, and they found that compared to sorafenib alone, SBRT improved OS and PFS in patients with HCC, and there was no observed increase in adverse events, and a strong suggestion of quality of life benefit was seen with SBRT. This study the accrual was closed early because the standard of care changed from sorafenib to other drugs, and that's why they didn't include more than 150 patients, and the study was, they started the evaluation. Protons is something which sounds very exciting because of their physical properties. We know that protons don't have any exit beam because of the Bragg peak phenomena. And because of this property, we theoretically, definitely, it has advantage in sparing the normal healthy tissue. So if, for example, if I'm treating a patient by photon, if I can treat a 10 centimeter tumor with photons, probably protons will push our limit, because with protons we have this confidence that we can spare the normal healthy liver. These are the recommendations from ASTRO. Again, they have indicated or they have suggested the role of radiation in different settings. Like as I said before, we can use in early stages, intermediate stages, and advanced stages, the different doses schedule based on the location, what kind of dose constraint we should be using. These have been defined by ASTRO very clearly, and this paper was published recently, and this is a very nice paper, and for all radoncs, they must study this paper so that we get this clarity where we should radiate, how much doses, how much fractionation can be used in what kind of patients. So just in brief, I'll go to the schematic workflow when we use SBRT. So for SBRT especially, and radiation in general, the steps are common. Basically, modern radiation depends on the imaging modalities, how fine you can image the tumor, because then only you can delineate this. Of course, CT scan plays a major important role. All our current radiation planning platforms, they work on CT-based platforms only. Of course, the fine or the thin slice CT scan, a triphasic CT scan, and an MRI is must when we are evaluating these patients. And the procedure, the steps include immobilization. As I said, if we cannot immobilize or we cannot fix a patient, it is very difficult to treat, especially most of the patients when if you are treating a patient where you do not have facility of respiratory tracking, gating. It is very important that you immobilize your patient properly. If you cannot, probably you should not try it. and especially in very high doses. If you are compromising on any of the part, you cannot deliver a very high dose of radiation. So immobilization is very important, because liver is a very mobile organ. When a patient lies supine for 10-15 minutes, there are a lot of motions. The motion ranges from 4 to 5 centimeter in certain directions, which is definitely unacceptable when we are giving a very high dose of radiation. So there has to be a way to compensate for that motion. It could be a real-time tracking or minimizing that motion by use of abdominal compression. So this is very important when we take any patient for SBRT. So target delineation, as I said, the most important step. Unless we define our target properly, we cannot treat it. So a triphasic CT scan, and if you have an MRI, it definitely should be used, especially for SBRT. If you are treating or giving conventional radiation, you can treat a patient on the basis of simple CT scan. But if you are considering a patient for SBRT, it is better if you have MRI, so that you can precisely delineate the boundaries, you can minimize the extra margins. So this is how the normal structures or organ at risks are also contoured and are reconstructed in a 3 dimensions, so that when we are giving a very high dose to our target, which is liver, we can at the same time spare these normal healthy tissues which are coming close to our target, like kidneys, rest of the liver, small bowel, chest wall. So any structure which is lying close to it, again there are certain set guidelines which we have to follow to draw these structures as well. Dose, again, as I said, it depends on multiple factors, the child score, the location. If it is lying very close to a critical structure, it is not advisable to give a very high dose because of the chances of complications. So if a disease is lying very close to bowel, we usually don't try to give very high dose. We rather try to fractionate it more. So instead of 3 fractions, I would rather prefer 5 or more fractions in these patients who have disease lying very close to critical structures. So the evaluation, we usually ask our physicists who plan the SBRT to follow certain constraints, especially when we are dealing with a patient who has cirrhosis. 700 cc is what we expect in a normal healthy individual. If he is having cirrhotic liver, we try to give even tighter constraints. The other structures like the central hepatobiliary tree, which has gained importance recently because of the frequent use of SBRT in our patients, the heart, kidney, chest wall, all these structures we give certain constraints, and these have to be respected. Otherwise, probably SBRT should not be tried if we are not following these constraints. I'll not go into the planning. So this is how our radiation plan looks like, and this is how our dose volume histogram looks like, a good coverage of the target and at the same time sparing of the normal tissue. If this is achieved, we usually approve these plans, and then the patients are taken for treatment delivery. Coming on to response assessment, this is very important and interesting, because most of the time when it is very important when a response evaluation is done, you are in close loop with the radiologist, because this response evaluation after SBRT is not the same as we do it after TACE or TARE. So the optimal time for response assessment is at least 6 to 12 months after SBRT. Stability of or decrease in lesion is associated with successful local control. Arterial phase hyperenhancement may persist after pathological CR. So there are certain features which usually confuse our radiologists, that there is a residual disease and the patient has not responded to SBRT, but these are the things which should be kept in mind when you are evaluating a patient after SBRT. The RECIST probably is not an ideal way to evaluate patients after SBRT. When we see these patients on follow-up, with TACE and TARE, we usually see necrosis by 4 to 6 weeks, but SBRT will show some changes by 3 to 6 months, and maximum response we usually expect around 12 weeks. So and again it depends on what kind of imaging modality you are using. It is ideally recommended to use a high energy triphasic contrast in an CT or MRI to assess the response. So this is an example, a patient, a disease marked in the planning CT scan. You can see in the first image. The second is after 3 months post SBRT, and the third one, the C image, is 15 months after SBRT. This is the kind of response we usually expect, but it takes time. It is, if you are in too much hurry, probably it will, confuse you more if you are doing more frequent imaging after SBRT, and you will feel the patient is still having disease. Talking about the toxicities, this is again a very important part when whenever we try a modality which is relatively new, relatively trying to establish itself. This is the thing which bothers us, because hepatocytes are very sensitive. Radiation-induced liver disease is something which bothers, but the classical radiation-induced liver disease, which is an acute triad of hepatomegaly, ascites, elevated ALPs, followed by development of anectic ascites. This is very rare after SBRTs, because I'm sure many of the doctors, in fact all of us, when we do SBRT, we are extra cautious. We do not, we strictly respect the dose constraints which are mentioned in the literature, and I have personally not seen any of these, especially the classic RILD, in any of my patients. Non-classical RILD, which is more common toxicity, yes, of course, this is common. And this is 5-fold or higher increase in the transaminase value, a decrease in liver functional, loosely defined as a 2-point or higher increase in CP score, reactivation of hepatitis. So these are the commoner toxicities. Yes, we see these, but most of these side effects or complications are manageable after SBRT. The common toxicity criteria which we usually follow, which grades nausea, fatigue, gastritis, and liver dysfunction, this must be followed when you are evaluating these patients. Other complications are related with the stomach, duodenum, bowel, the risk of perforation. Again, heart-related complications, though again, it depends on the location. If it is lying very close to left ventricle apex, there we have to be more cautious. But practically, we usually don't see any of the complications related to these structures. So the future directions, of course, there are many trials which are comparing, or in fact, they are evaluating the combination therapy of radiation with other modalities, other local therapies, other systemic therapies. Immunotherapy has come in a big way, and there are trials which are evaluating abscopal effects of immunotherapy with radiation. Thank you.
Excellent presentation, Dr. Sumi. A few points I want to make that in general SBRT is, we have a lot of experience now, even in lung also, even in bone metastasis, brain metastasis. So SBRT is not new for us. It might be new for the fraternity, but it is not new for us. The issue was there with the liver SBRT was the motion, the respiratory. It is very well controlled now. In every good center, in every institute, we have a different motion management systems which make our work very easy. And as Dr. Sami rightly said about the evaluation, most of the time we do in anxiety, we tend to investigate in 3 months, 4 months. It will not give you 100% advantage of SBRT, especially in HCC. Any question from the house or the other chairpersons?
In INASL algorithm, we have clicked SBRT on a stage B2 and stage C3. So in a clinical practice, so we have thought of only taste, tear, and RFA and that. So how to incorporate SBRT strongly with this patient should be subjected to it, or should be a financial decision that the patient is not subjected to tear, and in that case SBRT is much cheaper as compared to
I think our speaker would answer this better, that where should we position SBRT? because
So yeah, this is what we were discussing.
Actually,
Yeah.
I have the same question
Yeah.
for you, sir. That in the guideline, very well you have mentioned this criteria that in B till B2 and then C1, the both are actually having suggesting SBRT along with other treatments. But B3, which was not having the SBRT option as a treatment option. So I want to know why.
B3 is a tumor which is very diffuse and infiltrative. So what I we discussed that it could be a large tumor, very diffuse. So the residual liver, as you mentioned,
yes.
that would be difficult to achieve.
This is exactly what I said her, that probably this is because of the diffuse lesion. Although, as I said in my presentation also, nowadays the size probably is no more is a criteria for SBRT,
Exactly.
unless we are able to spare 700 cc. But of course, practically when we talk about a 5 centimeter tumor with diffuse margin, which makes it approximately 7 centimeter maximum diameter, and when you give additional margin to this 7 centimeter tumor, it becomes bit difficult. But then the option is we can modify our dose per fraction. We can still do SBRT while we will, but in this particular case, we will not give very high dose in every sitting. We'll try to do moderate hypofractionation in
Yes,
these kind
So
of patients.
when it is a diffuse and
Yes.
you're not able to delineate the
Yeah.
margin, then
Yes.
how do you decide?
So basically we take an extra margin.
Yes,
Of course, there'll be
exactly.
MRI.
So-
To compensate for that doubt about the margin, we will be taking some extra care in that area. And of course, as I said, we'll be keeping in mind that we are not giving a very high dose in a larger volume. And number 3 is the RTOG trial, which I mentioned. They have treated patients up to 10 centimeter size also. So probably size no more is a contraindication for SBRT
And
nowadays.
what about using PET-CT along with that? You know, if you,
Usually, MR and traffic CT is more than sufficient, and nowadays we do incorporate MRI in each and every patient. So we have now very good softwares. All the MRIs are incorporated in the planning CT scan, and we delineate on the MRI.
So I get, is this the advancement in the imaging that, if we have a better CT or an MR by which we can, delineate or we can see the disease properly, probably SBRT should not be an issue. Of course, if you are using an inferior imaging modality or of some inferior quality, it is challenging. Yes.
so I think we can add.
Current practice we are saying as an option of tear only.
Tear.
Yeah.
Option of tear. Where you are using tear, you can use SBRT like that.
Yeah.
What is
So.
the cost of
So as I said, as of now, again, we do not have any head-to-head comparison of TARE versus SBRT in this particular group, although there are trials which are comparing TARE to proton therapy. These are the randomized trial going on, and in fact, one of the retrospective study favored TARE over favored SBRT over TARE. But again, if you say that, of course, proton is not that common, it is not that commonly accessible for our patients. But still, there are no head-to-head or large randomized trial which have compared them.
what in practice we
Yeah.
would send the patient for tear to somewhere outside.
Yes.
So in Ahmedabad, if it is SBRT, is possible with
Yes.
We do very routinely.
So SBRT liver is very common nowadays, because almost all the centers, they have high-end equipments where they have good motion management. So SBRT is quite, it is probably, it was 10 years back that, one center in a state was doing SBRT. Now it is almost in every tier 2 city. All of the centers, they are doing it.
I think in
Yes,
last
sir.
6 months I have done 3 HCC SBRT in 3 to 4 months. So I think
Yeah, SBRT.
it is the same example.
Actually assess the patient, and if it is not at all possible to save 700 cc or something like that, then you can send them further.
So there is no absolute contraindication as such, apart from CTEC or less volume.
So as I said, the volume and the location, if it is not lying to, it is not infiltrating a bowel, or it is infiltrating ribs or chest wall, of course, these are the contraindication where you should not try. And if PVT, in fact, there are many studies which have done. Yes. For bridging, though, this is established. Yeah.
So
Yes.
like any data regarding comparison between patient with PVT and without PVT and response to SBRT, like less response, more response.
So No, probably, no, probably. I'm not aware of. Yeah.
No, for
No.
PVT, at least
Yes, sir.
SBRT is now becoming one of the treatment.
Yes, sir. Yes, sir. For PVT now, this is one of the standard treatment. Yeah. Yes.
extrahepatic disease, do we have any
No, in fact, my friend Dr. Dev Narayan Datta is in Kochi. He has published his series of doing SBRT in PVT only. He has treated over 40 patients and has published also.
He's one of the co-authors in the HCC.
Yeah.
About
okay,
that
yes.
paper only, we have just delivered one patient. I think Bhavesh is not there. The portal vein thrombosis. Just we have treated the thrombosis
Yeah.
out of the
Yeah.
main guideline.
Yes.
So it is possible now.
Yes, sir.
Dr. Sam. Patient will present with HCC report.
Yeah, yes, yes. Yeah.
The next option for them.
So I guess, so these are the patients who should be considered for SBRT for sure. Yes, sir.
Dr. Samir, is there any data on SBRT in non-cirrhotic liver with large tumors which are unresectable because of volume or vascular involvement? Is there any data?
So they are, I guess, they are case series only, which have treated. But again, most of the previous studies, they used to take a cutoff of 5 centimeter or so, sir. This is very recently after RTOG 1112 that we have started treating larger tumors because they included
Size cutoff?
So previously, as I said, it was 5 centimeter. Now probably there's no, practically there's no cutoff because in this trial, which was a large,
700.
yeah, by the time you are able to spare the 700 cc of normal liver, you can treat any liver, SCC.
Less than 700, we modify the dose.
The dose.
Won't be that effective. It is a moderate SBRT.
So if a 5 centimeter tumor is there and
Yes.
TACE is available and SBRT is available, you would...
So I showed one of the retrospective study, probably the combination is better, use both. It is not about comparing taste versus it is utilizing, it is better to use a synergistic way rather than, doing taste or SBRT.
Single SBRT was not much effective as compared to combination.
Yes, both.
But the combination was effective. Yeah, so as I said, yeah, it is the combination. Probably if the other arm would have been taste, the results would have been same. So it is the combination which works better.
Is there any cutoff of bilirubin level? So obviously child
So
C...
child
will-
C, of course, sir, not
but-
child C.
But if even in child B, if the bilirubin is say high 5 or 6,
So we have not strictly followed the bilirubin, we have followed the child and we have treated child B, good number of patients with child B, not C, of course. Yeah.
and what we gastroenterologists used to encounter that patients of like gynecological malignancies, they
Yes, sir.
come with radiation enteritis later
Yes,
on. So
yes.
are there, episodes of radiation enteritis
So,
after the
especially,
SBR?
sir, in gynec cancer, especially the cancer of the cervix, we give a very high dose of radiation, and radiation in the rectum lies very close to our target. But in SBRT, luckily, as I said, if the disease is very close to bowel, we are a bit conservative about our doses. Small bowel is very sensitive to radiation, and we definitely respect the dose constraints to small bowel.
Actually, that is also based on how the patient has been treated for cervical malignancy. Because if we treat under image guidance, which is called IGRD,
Yeah.
then those patients are likely not to be having enteritis, radiation-induced enteritis
Yeah.
in the future. But those actually who has received, the basic techniques like 2D or 3D CRT, then those patients are very prone to develop enteritis. So
Yes.
for those patients, actually you need to know that how those patients had been treated.
The external
which
radiation
modality.
part is also very important. In
Yes,
fact,
how
nowadays,
they
most of
plan.
our patients nowadays are treated under image guidance, but this was not so common few years back. So this could be one of the reasons, sir. You will not see enteritis that much nowadays if the patient has been treated under image guidance.
So what is the usual cost in Ahmedabad?
For SBRT, sir?
For liver?
So I guess 3 of us are sitting from different centers. 3 of us will charge differently, sir. So roughly it will be around somewhere between 2 to 3 lakhs.
Less than
Yes.
Tarrant test.
So I think it is 1.5 lakh.
So
to
it
2.5
varies from
lakh
center,
between somewhere
almost,
there.
yeah.
So each and every
It varies.
institute has their own set.
covered under my
Yes, yes.
It is also
So
covered under
again,
insurance.
Ayushman, yes, Ayushman is having
Yeah.
SBI protocols, yeah, so we can treat with under that
Yes.
also.
Yeah.
Yes. And just for one information, carbon ion is also
Yeah.
going on the study, which will be
So yes, particle therapy is something which is, although this is not very freely available in India, of course now we have second center, Tata Memorial also has also started protons, and I am sure in next 5-10 years there will be 2 or 3 more centers in all corners of India at least, and the cost of therapy will also significantly go down. Then definitely this will also be one of the very, probably a good option for SBRT for our patients. Thank you. Thank you, sir.
Thank you, chairpersons, moderators, and speaker. So now we'll break for a short tea break, 15 minutes, and then we'll reassemble.
मैंने ये लगा दिया, देख लो वहाँ से। बरोबर अच्छा भाई। HDMI लगाई दी। हाय, बस बढ़िया। इसमें थोड़ा एमा करंट आवा है, मैंने लगा दिया है। भाई ये सी पोर्ट भी है इसमें, सी पोर्ट
ये अटैच कर देगा सर। आप टीवी एक एंजॉय कीजिए, फिर आप आ जाना।
नहीं इसमें मैं चेक में ये हो नहीं, उसमें नहीं हो जाना चाहिए। क्यों नहीं हुआ? देखो ना वहाँ से कुछ हुआ इश्यू। तो तुम्हारे बीजो केबल हो तो ले लो ना।
ना ना हमारू केबल टेस्टिंग करेलू છે ચાલુ જ છે।
कुछ और वायर में इश्यू ना हो, देखो ना। ये तो लगाओ, ये तो सी टाइप है आपके पास केबल?
सी टाइप? हाँ है।
तो सी टाइप लगा दो ना। नहीं
हाँ सी टाइप है।
ये तो सी टाइप का ही है, तो ये इसमें HDMI लगा दो ना। हाँ पर यही लगाया, सेम है। लो
ठीक है सर, तो अपना लैपटॉप ले जाएंगे।
मिनट एना करता વધારે સારું
हाँ तो कर लूँगा ना सर के बाद आपका ये केबल आपके इसमें ही लग जाएगा ना आपका भी हो जाएगा डिस्प्ले सेटिंग में
लेकिन जब सबका सेशन चल रहा होगा
ये है ना
आओगे कैसे?
तो वहाँ पे भी है उधर भी आपको कनेक्ट करके दे सकता हूँ इधर ही करना है
यहाँ कनेक्ट नहीं करना,
हो
मुझे यहाँ
जाएगा, चलो।
कनेक्ट करना है स्पीकर के लिए। यहाँ पे उसको भी चाहिए होता है यहाँ पे।
देखो ત્યાં ચાલુ કરો
चालू है सर इज कनेक्टेड
આમાં તો થાય જ છે આ તો રોજ યુઝ કરું ઓફિસમાં કોઈ પ્રોબ્લેમ નથી હા
सर आप मेल पे कर दीजिए,
हैं
मेल पे कर दीजिए, मैं अपना।
नहीं इसमें बहुत सारे हेवी वीडियो है मैं नहीं कर सकता मैं वीडियो चलेगी नहीं
अच्छा
इसलिए तो बस एक देखो ना इसमें
बस मैंने कल दिनेश भाई को बोला था क्या
नहीं है ना सी टाइप का ही कनेक्टर है
ચાલુ है ये HDMI भैया टेक्निकल मानस ने कोई ने को यार ये ले लो ना भैया, ये लगाया हुआ है पीछे, रिजोल्यूशन का इश्यू था।
हाँ, और रेजोल्यूशन ज़्यादा है ना, इसलिए आउटपुट नहीं दे रहा है।
अच्छा, अब हो जाएगा। ठीक है, तो इसको मैं स्टॉप कर देता हूँ। ठीक है।
सर आपका अब चल गया ना, आप टी कॉफी ले लीजिए, अभी है टाइम।
हाँ, मैं देख लेता हूँ, मेरा वीडियो चल रहा है ना, और कुछ नहीं।
वीडियो चेक कर लीजिए।
नहीं, ऑडियो नहीं है, मैं खुद ही ऑडियो हूँ। बस ये इम्पोर्टेंट है, क्योंकि बस मेरे को ज़्यादा टाइम नहीं लगेगा। आई एम ओके विद कॉफ़ी ऑल्सो। आई मीन, इफ़ यू वांट टू स्टार्ट वी कैन स्टार्ट।
We are about to begin. I request everyone to come inside the hall. You can carry your cup of coffee and come inside. So, welcome back after the short tea break. So, we are about to begin, and our next three talks would be basically on surgical aspects of the liver of HCC. So, the first talk would be basically on liver resection for HCC. And for this, I would request the moderator, Dr. Amit Shah, and chairpersons Dr. Abhinav Jain, Dr. Neil Palkhiwala, and Dr. Dhaval Rajde to come onto the stage. And I request the chairpersons and the moderator to introduce the next speaker, Dr. Hitesh Chavda. You can begin the session.
Yeah. Thank you for the opportunity. Dr. Hitesh Chavda is known to us. He is a senior HPB and liver transplant surgeon from our city, from Sterling Hospital. And without wasting more time, may I request him to proceed with his talk.
Good evening, everyone. I thank INASL for giving me this opportunity. I'm going to talk on surgical aspect of management of HCC. As you know, HCC is a very common cancer, more than 8 lakh deaths per year, and it's a leading cause of death in patients who suffer from cirrhosis. If you don't treat this cancer, the overall survival is dismal. Now, HCC is very different from other cancer because we are dealing with two diseases. One is underlying liver cirrhosis, and second is the tumor itself. So it's very unique cancer compared to other cancers, and it's challenging also. And there has been a paradigm shift in the etiology of liver cancer. Most of them will have liver cirrhosis, and there has been a shift from chronic Hep B, C to metabolic reasons like NAFLD or alcoholic related liver disease. So, and it becomes more challenging because of this to manage such patients and to resect them. So regarding the treatment modalities, we are discussing various treatment modalities like surgery to ablative techniques, transcatheter therapies, SBRT, and systemic therapy that we are going to discuss today. Subsequently, I'm going to talk on liver resections. Now, liver is a unique organ which regenerates once we resect it. But liver regeneration is hampered if the parenchyma is not normal. So that makes it more challenging, and that makes it more difficult to evaluate preoperatively. So now we see a lot of advancement in the field of liver surgery in form of lot of advancement in imaging, good anesthesia, lot of gadgets for a parenchymal transaction, navigation system, ICG, laparoscopic surgery, transplant techniques, portal vein embolization, ALBS, etc. So we can push our boundaries to resect these patients case-to-case basis. So regarding the indications and selection, broadly, solitary HCC without vascular invasion, preservation or preserved liver function with adequate future liver remnant, no or minimal portal hypertension. So these are the ideal patients for resections. And we are just discussing a lot of guidelines. It falls into stage 0 and stage A. So early stage HCC are the patients who are qualified for resection. So this is the other BCLC staging system, and just sir discussed about the INASL modification of BCLC. The BCLC has got its own problem. It does not consider location of the tumor, which is very important for resection. It also, not good for non-cirrhotic liver. And it does not respect etiology of liver cirrhosis. And many patients who belong to Child's B, who are traditionally offered other therapies, may be resectable surgically. So BCLC surgical system has got its own limitations, and we have just discussed, and we have also heard the modifications. So there are a lot of modification happening very frequently. Many guidelines from Asia, Europe, and US. There has been a difference between the Eastern and the Western guidelines. The Eastern people or Eastern surgeons are more aggressive, and we see more option of resections in the Eastern guidelines compared to Western guidelines. And this is the recently published ASCLD guidelines, which says that early stage HCC, single lesion, child's A cirrhotic liver with no portal hypertension is a good candidate for liver resection. And there are INASL guidelines which also shows the same thing. Early child's A cirrhosis, preserved liver functions are candidate for transplant. This is the Japanese guidelines. These people are a little more aggressive compared to the Western world. So broadly, no extrahepatic disease, no macrovascular invasion, solitary lesion, child's A cirrhotic. In normal liver, about 25-30% remnant liver. In cirrhotic, more than 40% liver remnant. Minimal portal hypertension, good performance status. These are the patients who will tolerate liver resection. Otherwise, they'll get complications, and this is our own Indian guidelines. We just discussed 2019, which also shows the same thing, a non-cirrhotic liver. If you do R0 resection with adequate liver remnant with minimal portal hypertension are good for liver resections, and this is the latest guidelines for intermediate and advanced HCC that we just discussed in the previous lecture. So these patients need proper preoperative evaluation in form of liver function test. We do coagulation profile, we see platelet, volumetry, CTP, MELD score, upper GI scopy to see for varices. HVPG, we don't do it as a routine thing, and also ICG also we don't do. So the most important thing is to know how much liver remains behind, and secondly, what is the quality of liver. This is very important. So our whole preoperative evaluation should focus on the underlying liver disease, liver function status, status of the portal hypertension, and also volume. If a patient has a normal liver, not cirrhotic liver, but a fatty liver or a NASH, these patients, if they undergo a major liver resection, they are very likely to develop postoperative liver failure. So this has to be properly evaluated prior to surgery to have a successful outcome when we plan for a resection. This is Makuchi criteria, which takes into account the bilirubin level and ICG. We don't usually follow this, but it is well recognized. And the contraindications are extrahepatic disease, bilobar disease, decompensated liver disease, significant portal hypertension, involvement of the bile duct, thrombosed veins, IVC, and performance status. If it's not good, we should not offer these patients resections because the mortality is going to be very high. So if you see the outcome, compared to other modalities, HCC or hepatic resections, the 5-year survival is about 40 to 70%, and 70% of these patients will develop recurrence at 5 years. So you can see the comparison with the other modality of treatment. So we have to tailor our approach according to what we see. So there has to be an individualized approach to offer treatment for the patients who have HCC. And the outcome depends upon the size of the tumor, the number, location, the remnant liver, and also the factors like the comorbidities, the performance status, and also surgeon factors like the bleeding at the time of surgery, the remnant liver, the vascularity of the remnant liver, blood loss, etc. So all this matters when we plan a major resection, and also the multicentricity of the tumor, preoperative alpha fetoprotein level. If the alpha fetoprotein is 10,000, there is no point resecting these patients. So these patients are likely to recur, and of course, lack of capsule, poorly differentiated malignancy. These all are the factors that will have a very early high recurrence after the resection. If you see the literature, majority of the series will show a 5-year survival of about 50%. So even the older literature will show the same 5-year survival. And if you see the comparison with resection and transplant, these series will also show a similar outcome at 5 years. So this is the series of resections recently published shows a 5-year overall survival and disease-free survival. So overall survival is about 50% after resection for HCC. So technically, the basic aspect is to do a proper exposure to a J or a Mercedes incision. We use intraoperative ultrasound, inflow control, outflow control, preserve biliary tree, parenchymal transaction with whatever technique you are suitable with. Low CVP is very important, otherwise there is going to be bleeding. IVC should not be very tight, and we have to minimize the blood loss. So these patients will do well if there is a less blood loss. So the primary goal is to have at least 1 centimeter margin, and there has to be an adequate future river remnant. So there is something called anatomical resection and non-anatomical resection. We do non-anatomical resections mainly for metastatic disease. For HCC, it is usually recommended that we do an anatomical resection. Anatomical resection means we have to follow the segmental anatomy. So it's a right hepatectomy or a left hepatectomy according to these classifications. If we do a segmental resection, the anatomical resections, the overall outcome will be better compared to patients who undergoes a non-anatomical resection. So the main concept is that the tumor nodules or tumor cells travels through the portal vein tributaries, and if we take that branch of portal vein together with the resections, the chances of recurrence will be less. And if we do a wedge resections, then possibly the remaining tumor cells will cause recurrence in that area. And if you see the anatomical compared to non-anatomical resections, the overall survival is quite different, and we should always try to do an anatomical resections to prevent recurrence in patients with HCC. It has shown in many studies that anatomical resection is far better for overall reducing the tumor recurrence and improve the overall survival. Now, how to increase resectability in patients with HCC? So there are various modalities like portal vein embolization, sequential, TACE, and portal vein embolization. ALPS is also used for HCC. And another exciting area is neoadjuvant therapy. That is coming up in a big way now to increase resectability in patients with HCC. So in portal vein embolization now it's routinely performed in patients who have smaller liver remnant. The same side, the tumor side is embolized, and we have to wait for the hypertrophy on the other side, and then eventually these patients undergo resections where there is a huge amount of liver which remains behind, and it will prevent a post-operative liver failure. Even preoperative TACE or TACE followed by portal vein embolization will also help, and it has shown in the studies that if we do TACE plus portal vein embolization, the overall outcome is better compared to only portal vein embolization. This is a patient whom it was our trial patient. You can see a huge HCC on the right side. We did a chemoembolization. She received 2 or 3 cycles of chemoembolization. She was not having a good performance status, not affording as well. And finally, after 1.5 years, you can see the tumor has become very small. The liver has also got very bigger in size, and now she is offered a curative resection. So this can be offered to downsize such patients, and a curative resection can be offered after chemoembolization and also portal vein embolization. Regarding ALPS is usually used for patients who have metastatic disease and not primary for HCC, but it can also be used for HCC, and very few patients for it is used for cholangio. So primary for metastatic disease, but selected patients with HCC can also have ALPS, and the primary idea is it's a two-stage procedure. In the first stage, the liver is transected, right side of the portal vein or the same side of the portal vein is ligated, and then all the pedicles are slinged. We do a volumetry after 7 to 10 days. There is a rapid hypertrophy compared to portal vein embolization, and then we go in again, and before that we do a volumetry and resect that portion. So this patient will have a rapid hypertrophy in a short span of time, and can have less chance of liver failure. So, but it's a very major procedure. Two major procedures will carry a high morbidity and mortality. As I said, this is the diagram shows this is a small liver remnant. This is the first step, and then you can see everything is dissected, and in the same stage, a bag is applied at that time. The pedicles are ligated, artery is sling, bile duct is sling, transaction is done. There are a lot of modification of this technique. Even laparoscopy is also done if you want to minimize the trauma to the patient in the first stage. In the second stage, you see a hypertrophy and remove this side of the liver. And then before that, we do a volumetry to measure that there is an adequate liver before we go in, and these patients, they end up with a curative resections. So the first step, you go in, you see a small liver remnant, there is a large tumor on the right side. These patients are likely to develop liver failure. You can see a small liver, a right side portal vein is dissected, an artery and bile duct is also dissected, and you can see a clip is applied on the portal vein, and 2 clips were applied on the portal vein. The liver parenchymal transaction is done, and then once it is done, we put the slings and everything inside. This patient had also had a hanging maneuver also because the tumor was very large. So you can see a hanging maneuver is there. There's an artery tube which is passed. So this is the portal vein. This is the right hepatic artery, and this patient had, this is the parenchymal transaction. After doing parenchymal transaction, we put a small plastic in between the 2 lobes, and so that there is no collaterals developing between the 2 lobes, and then we put this liver in a bag, close the abdomen. So this is a bag, there is a plastic in between so that there is no collateral. We put this in a bag, close the abdomen, and then reassess this patient after a week, 10 days, 15 days, depending on the hypertrophy. So this is how it is closed. This is the hanging maneuvers. And stage 2, we go in again, and then see a lot of adhesions inside, and then everything is dissected. The transaction is completed. The vein, artery, bile duct, everything is decided, and the tumor is removed. So this is how the ALPS procedure is done. You can see a large tumor which is resected, and there is a remnant there. This is a huge tumor which was otherwise not resectable, and that's the so it looks bloody. It's a very major procedure, has got a very higher mortality. So the reason why we do ALPS is to increase, why there is a hypertrophy, because there is increase in the portal flay on the remnant side, and the transaction, because it will prevent the collateral formation and also stimulate the growth factors for regeneration. So it is mainly used for metastatic disease, but also for HCC, and so it's a good, bad and ugly. So selected patient for HCC can have ALPS procedure. Laparoscopic liver resection, robotic surgery is beyond scope of today's talk, because it's another talk separately, so I'll not discuss. I'll discuss about large HCC. We see a lot of large HCC in our practice, and it's not always a contraindication. It is safe and effective options, particularly patients who have normal liver, normal liver in the background, and if there is no vascular involvement, if we resect such patients, the overall survival, you can see 5-year survival is about 30%. So this you can see more than 100 patient series, and the 5-year survival is about 30%. So this is very important. I'll show our own data for large HCC at our center. We have resected 34 patients who have tumor more than 10 centimeter, the median age was 58, cirrhotics were 20%, the average size was 12, vascular invasion was in 61%, the average hospital stay was 8.5 days, the morbidity was 23% and the mortality was 2.9. These are the different resections that were performed for these tumors. The median follow-up was 34 months, and you can see the overall recurrence-free survival at 1, 2, and 3 years was 66, 40, and 30%, and overall survival was 69, 53, and 23% at 1, 2, and 3 years. So, large HCC is not always a contraindication. Depending on location, background of liver, and your expertise, these tumors can be resected. You can see there is a large tumor. There are various techniques. Otherwise, this looks inoperable. I mean, you can see a huge tumor in the right lobe with a normal liver, which is already hypertrophy. You can see almost the entire right abdomen is full. So we have done an anterior approach. We did not mobilize the liver. We just transected and reached up to the IVC and removed the liver. So this is called an anterior approach, and this was done about 5 years back. This patient died due to corona. I mean, he did not have a recurrence. So you can see we did not do anything. We just reached at the porta. We ligated the right branch of the portal vein and artery, and then just transected the liver because it was impossible to mobilize. So normally, conventionally, we mobilize and then do all the pedicle and everything. But you can see here, we transected, reached up to pedicle. So you can see this was done in 2018. So you can see the liver is open like a book now. There was hardly any space between IVC and liver, hardly any. This is the caudate lobe. So we again try to, dissect the liver at the inferior margin, slightly mobilized, made a space in that area, and went close to IVC. And you can see, then eventually reached up to the right hepatic vein. Then you can see a huge liver tumor here. So you can see now at the site of right hepatic vein, this is the remnant liver on that side, and this is the right hepatic vein which is clamped. It is transected, and you can see the tumor is removed. So this is possible with these type of techniques. Like you can see a huge tumor. This patient did very well post-operatively, and you can see normal liver, very vascular red liver on that. This is the IVC, and this is the site of the tumor. So with these type of techniques, for a large HCC, a successful resection can be performed. And also there is something called repeat liver resection. I mean, selected group of patients who are not qualified for other type of treatment, who doesn't want to undergo salvage transplant. This small subset of patient can have a second resections, provided there was a single HCC on the first time, disease-free survival was more than 1 year, and there is no vascular involvement. So such patients can have resections. I mean, we have resected a few of them. I'll quickly show a small video. So these gentlemen had laparoscopic resection a few years ago. He was on waiting list, then he was delisted, and then eventually had tumor recurrence on the follow-up. He was still not ready for transplant, and then we resected him. He had an early cirrhosis. You can see a tumor in the middle of liver, which was close to the vascular pedicle. And this gentleman had a second surgery. You can see this was a tumor in the center of the liver. So he had a second resections. So you can see this is the intraoperative ultrasound, which is used in such patients, which is close to the pedicle here, and had a wedge resection. And he was again came for option of exploring transplant. So this is the intraoperative ultrasound, and this is the tumor which was resected. So this is a wedge resection in this patient. So this subgroup of patients, very selected group of patients, can have repeat resections. Now, regarding adjuvant and neoadjuvant therapy for HCC, this is coming up in a big way. We will hear our oncologists talking on this. There are a lot of papers now, and depending on whether it's type 1 or type 2 recurrence, they have advocated the therapy, and you can see a lot of trials going on in coming few years. We are going to have so many drugs, so many protocols now which can be used for adjuvant therapy after resection for HCC. Currently, we are just following these patients. We are not giving them anything. There are so many trials actually. So we will have something now as an adjuvant therapy for these patients. So to summarize my talk, I would say there has been a significant progress in the field of liver surgery, in preoperative diagnosis, intraoperative treatment, postoperative care, and it has got an acceptable postoperative morbidity with a good 3 and 5 year survival. Indications for hepatectomy for intermediate and advanced HCC can be expanded in selected group of patients. Laparoscopy is progressing now and has got equivalent good results in trained hands. Re-resection for very selected patients, and we still need a good tool to characterize biology of HCC, and HCC management is always a multidisciplinary approach. As we have discussed, we need everybody to decide what is the best for that particular patients to have a good outcome. Thank you very much.
Thank you, Dr. Chawda. Is there any question for Dr. Chawda? Yes.
First of all, a very good talk, sir. Thank you for that. My question is, how do you select your patients for ALPS in HCC? Because if a patient, we are considering ALPS, which the first thing which one would prefer is to do a portal vein embolization or a sequential TACE followed by PVE. The fact that we are considering ALPS means the patient has probably not responded to PVE or sequential TACE followed by PVE. So how do you select? Because again, there is a chance that the patient may not respond to ALPS 2 because of the poor liver quality.
So the liver has to be normal. Patient has to have ECOG 0 or maybe 1. Another thing is, many a times portal vein is, compressed with the tumor. It's a huge tumor, so you cannot reach to portal vein. It's not easy to puncture portal vein. So to embolize portal vein may not be easy in such patient. It may not be seen also. So in such patient, we have to discuss with the interventional radiologist.
So you suggest in such patients we go for an upfront ALPS rather than...
Depends. You have to think so many things. You have to do volumetry, you have to see the vascular anatomy, so many things, and then decide for ALPS. ALPS has got a very, high morbidity. Okay. So portal vein is usually not seen properly. That's what I'm trying to say. Because the tumor is so big, just near the bifurcation you will not see anything. So maybe you cannot reach there to embolize it.
So to put...
and another thing is, in such patients, it also involves segment 4. So what is left is segment 2, 3 and caudate. So you are actually planning an extended resection with a small left lobe.
So in such patient, if you've done a TACE with PV, the volume enhancement has not happened to what one would anticipate. And so these patients, would you consider ALPS in such a patient who's not responded after a TACE and a sequential TACE and PV?
Maybe, yeah.
Okay. And post-ALPS, especially when you are contemplating an extended right resection, what is your experience with liver behaving like a small 4 size where you're just a small volume?
It can. I don't have a huge experience, so I'm not the right person to, but it can. ALPS is, you have to be very careful selecting. It's not a routine thing to do.
Yeah, I think if you are planning ALPS in HCC, means you have to be very sure the underlying liver is very normal.
A problem.
Is normal, yeah.
So how do you assess the underlying liver? You should do a left lobe biopsy also. So that will give you an idea how is the left lobe. Because if it is not going to regenerate, then you are in a problem.
So, do you do liver biopsy of that remnant liver routinely?
We have to do.
Yes.
We have to do. Otherwise, you have to do 2 stage and you actually don't do anything. That's a problem.
Yeah.
You put a bag and then you remove the bag. That's a problem. So you have to be, and counseling is very important because patients should understand what you are doing. ALPS is a very advanced thing and patients should understand what exactly we are doing. You have to counsel them properly and then do it and it is very expensive.
Yeah. And when we are doing extended liver resections in HCC and we are worried about underlying portal hypertension, so are you, doing any type of HVPG measurement before
No.
liver resection or any portal flow modulation during surgery?
No.
Intraoperatively
I mean,
also?
I've never done HVPG. I think ILBS has the highest experience of doing HVPG. So maybe Ashish sir can.
Yeah, we do a HVPG, but HVPG is like in Gangaram we are doing HVPG, but it is not there in most of the centers. So most of the time what we rely, what is there in the guidelines also, that you'll look at platelet count, you'll look at varices, and then if the varices are there, then obviously these patients have clinically significant portal hypertension, so you'll not do liver resection in them.
The initial enthusiasm for ALPS seems to be waning now, and select.
Be very careful.
And sir, one last question. How would your approach differ in managing a ruptured HCC in a cirrhotic vis-a-vis a non-cirrhotic?
So what we do is we first embolize them. You know, if there is a ruptured HCC, we embolize, stabilize, then we see how they do, and then try to resect if it is resectable. We have resected a couple of them. I mean, if it's a huge HCC, anyway not resectable, there is no, then you just do a TACE and then take it forward. Maybe do pigtail, drain the blood, depending on how much hemoperitoneum is there. But if it's a localized rupture, then we usually do a TACE or just embolize it, stabilize everything, then take up for resection if it is resectable, and depending on how is the other portion of liver, performance status, age, etc. So, but it is possible. We have done resections, I mean, quite a few.
Thank you, sir.
Yeah.
One question. Resections, we generally were doing very less till now because of portal hypertension and so it was in my last practice about 10, 12 years, hardly sent patients for resection. But in last 2-3 years, we are seeing more and more patients who are coming with HCC in non-cirrhotic livers, especially NASH related. So with this, I think the frequency of resection.
Yeah.
So what is your experience?
I mean, we started resections about 15 years back. So it was very primitive. So at that time also, I mean, we were also new. So we have seen many patients who, when we open up, they have a cirrhotic, NASH. And we have lost patient post-operatively because we were not that, knowing about that these patients may behave oddly. They become acidotic post-operatively, they need CRRT, and then they come out. We have seen this thing also in a Hep C patient, because we try to do a non-anatomical resection, but they also behave bad. So we have to be very, because liver may not look cirrhotic, but it can be fibrotic, and if you are doing an aggressive resections, they behave very bad post-operatively. I mean, unpredictably they, succumb. So we are very careful. When we open up also, we are very careful and try to do biopsy also if we have any doubt, and if the margin looks rounded, if patient has all metabolic issue, diabetic, obese, all that type, then we have to be very careful.
So patient selection is
yeah, very important. I mean, we see everything in detail, then we offer them. Otherwise, you get stuck, and unpredictably you will get stuck. So,
in a case of portal vein embolization, if the liver has not, FLR has not increased what is needed for surgery, then can the patient be taken up for surgery because the patient has tolerated portal vein embolization?
you can, but can we do tear in such patient?
Yes, tear has the atrophy.
Because tear will cause more atrophy on that side and maybe hypertrophy on the other side, if patient can afford.
But it takes more time than the portal
so
vein, 6 months
maybe
probably.
But we can add even arterial embolization. If portal vein embolization didn't work, you can try arterial embolization. That may also work in few cases, not all cases. But the thing that in those patients, we should not go for surgery that enthusiastically because the hypertrophy is not happening. So the post-operative regeneration may be a problem. I think that we have faced these issues initially. So if it is not regenerating, then you should be more cautious now.
And sir, there are recent data that suggests that simultaneous portal vein and hepatic venous deprivation.
Yes.
So that will give more FLR and more
Yes.
hypertrophy of the
I have not.
left side.
No, I have not done. Portal vein, yes, but not hepatic vein.
Simultaneous we
It
can
all
do, sir.
depends on IR, no? How aggressive.
Yes.
For patients with HCC and portal vein thrombosis, so theoretically up to VP2, that up to segmental involvement, it can be operated.
Should
but
be resected, yes.
practically, I don't know if...
we have done that also, I mean, intentionally in the past, and some of them had recurrence, some of them did not. Maybe biology is a thing, but we had one patient 5-6 years back, we resected with VP2, had HCC with cholangio type of biopsy, then had systemic treatment and also local radiation, and did quite well. So it should be done actually. If you can resect it for VP2 is good, you should resect it. And provided the liver is okay, if you think that patient should tolerate the procedure.
I just have one question, sir. Recently now the adjuvant data is coming up. Are you now referring patient for adjuvant therapy?
I think it is not still accepted one. Is it?
It's a large trial, RCT has come.
Okay, no, but it is still in practice, is recommended?
It's not in recommended.
Yeah, so I am aware about it, but we have still so far not. We just follow them up every 3 months. First 3 months we do ultrasound, blood test, X-ray, then we do next 3 months CT and all that follow like that. If it's cirrhotic, then we do MRI rather than CT. So, but so far I have not started any adjuvant, but we look forward to it because they do have recurrence, and then it's quite challenging.
For large HCCs, one comment was that for atypical HCCs like fibrolamellar HCC, even they do very good.
Yes. We have a good experience of doing large HCC, so they do quite well. I mean, and it's common to see large HCC. We see a lot of large HCC. So, fibrolamellar they usually do well. Yeah.
And how do we follow these patients after resecting a large tumor? How do we, suppose patient is having a large SCC, and the biology shows that it is a well-differentiated tumor, no microvascular invasion.
So that's what I said. I mean, what we follow is we follow them up every 3 months for 2 years, and then 6 months for another 3 years, and then yearly for another 5 years. So 10-year follow-up. This is our protocol. So 3 months you do ultrasound, blood test with AFP and PIVCA, whatever you do, and X-ray chest. And another 3 months means at 6 months you do a CT or MRI depending on what you have done previously, or cirrhotic do MRI, and then same thing you do for 2 months, 2 years, then 6 monthly for 3 years, and then yearly for another 5 years.
So suppose if a patient comes up with a tumor less than 5 centimeter or so in the remnant liver within 2 years, and irrespective of size of the primary tumor, index surgery, should we consider salvage LT in such cases or not, or it is
salvage you should do? I mean, 5 centimeter tumor?
Irrespective of the size of the primary tumor.
I think you should do it. I mean, you are talking about transplant.
Yeah.
I think you should do. What do you say, Dr. Anand?
Yeah, so even if the primary tumor is more than 10 centimeter, we should not hesitate for going in for liver transplant.
Yeah, so when you say we shouldn't, I'm answering I wouldn't. You know, when you shouldn't, you're talking about the maturity of the data and what is the level of evidence which it has been accepted as. You know, you don't really have a formal guidelines for assessing a patient with tumor for transplant based on downstaging. So downstaging is practiced, and it is accepted within various OPOs based on their own criteria. But there is no uniform UNOS guideline which has kind of resulted into a white paper or resulted into a kind of guidelines based on that. So the fundamental belief system or the purpose for which you downstage is you bring him down to within Milan.
Conventional.
So at the end of your downstaging, if the patient is within Milan and you have followed the patient up for like 3 to 6 months or whatever you believe in, and if there is no systemic metastasis anywhere else and the tumor is still within within the confines of the liver and not infiltrated vascular structures, absolutely. Otherwise, there was no purpose of the initial downstaging exercise.
So does this mean that liver resection is, one of the best modality to downstage the tumor? Because we will have biology of the tumor in our hands. Because we are worried about biology when we are subjecting a patient to transplant.
Yeah, but the biggest problem is the quality of the parenchyma. Most of these HCCs happen in cirrhotic livers, and you don't really have the luxury of resecting them most of the times and allowing the biology to tell you which way to go forward. Even wait for a recurrence to become 5 centimeters and the patient is still compensated and allowing you to, that's
very rare.
I really,
yeah.
One thing, Chawda Sahib, you repeated 2-3 times that if it is a cirrhotic, you would do an MRI instead of a CT. Why so?
And we are more happy with MRI. I mean, this we have started recently.
Is it because of your radiologists?
Because of radiology, and we have 2 trials who has MRI as a protocol. So we are very happy with reporting MRI compared to.
It has nothing to do with the gadolinium being less toxic.
No.
It's just
and secondly,
your institutional preference.
No. Secondly, because we see lot of NASH related liver with HCC and also cirrhotic. So I think MRI, we are very comfortable with MRI now.
The quality of images is
Yes, and the reporting is very perfect. And we have seen, the regenerative nodule being, reported at HCC, and you will see reporting as there are multiple liver tumor. But actually when you do an MRI in cirrhotic background, they will say that whether it's LR1, 2, 3, 4, 5, and you exactly know which to target. So that's why it becomes we are very comfortable using MRI now.
MRI is more sensitive.
More to do with your radiologist.
Yeah, so
I can see the exact opposite for CT scan versus MRI.
No. I'm really telling you, we are very happy. And yeah, for HCC, we are very comfortable now. When we see, sometimes we do MRI even if patient had an CT. So that's how it works. And probably because we see it routinely and we discuss with the radiologist almost all the cases. So maybe.
But lately there is some data to suggest that for small tumors and these tumor in the background of lots of regenerating nodules, MRI slightly scores over CT scan.
Okay, I think we should conclude the session. Thank you, Dr. Chawda, and thank you everybody. Thank you.
Thank you.
Thank you, chairpersons, moderators, and Dr. Chawda for this session. For the next session is on downstaging therapy. It was by Dr. Chirag Desai, but I think he's stuck on liver transplantation. So instead of him, I would be presenting some downstaging. So I would like to invite as chairpersons Dr. Dhaval Gupta, Dr. Manas Vaishnav, Dr. Maitri Patel, Dr. Ankit Thakkar, and as moderator, Dr. Manish Gandhi to come on to the dais.
For the next session, downstaging protocol, we have Dr. Asis. Dr. Asis is a senior consultant at Gangaram Sir Gangaram Hospital, professor and senior consultant. So, sir, please.
Thank you. So I would be talking about downstaging therapy for HCC before liver transplantations. So I would first like to present two cases. 58-year-old male. He presents with, he's a follow-up case of diabetes for 18 years, hypertension, and he was diagnosed cirrhosis 3 years ago, but now he was lost to follow-up for last 3 years. But now he presents with pain abdomen, and on investigation there was a 4.5 centimeter of HCC in the right lobe, no portal vein thrombosis, no extrahepatic spread. The tumor is within the Milan criteria. Alpha fetoprotein is normal, and his CTP score is 7/15, and he is listed for transplantation, but he has no donors. So he told that he may get he may be able to arrange donors as well as money for transplantation, but it would take more than 6 months. Another case, everything similar, long-standing diabetes and cirrhosis, but he has this patient has a bigger tumor, 7.5 centimeter HCC in right lobe of liver, no portal vein thrombosis, no extrahepatic spread. The tumor is beyond Milan and UCSF. He's ready for transplantation, son is donor, but he's now told that he's beyond transplant criteria. So these two cases I have brought out to differentiate between what is bridging therapy and what is downstaging therapy. So when you have a case of HCC where he fits into the liver transplantation criteria, but he's not able to get the donor or transplantation soon, and there's a lot of time, he's on the waiting list, or he's arranging money, or the donors are not available. So if the time period is more than 6 months, then this patient would probably merit from bridging therapy. That means we'll bridge till he gets the liver transplantation. But in the second case, when the tumor is much more large or beyond the transplant guidelines, so this patient would benefit from downstaging therapy. So bridging, the definition of bridging therapy is that bridging treatments are new adjuvant therapies given to patients on waiting list for liver transplantation within criteria with the aim to reduce the disease progression and therefore to dropout rate. And usually bridging therapies are done in the LDLT setting, mostly in the Western countries where the patient is on the waiting list, but it is taking time. Potential advantages is that it prevents the progression while he is waiting for the transplant. It decreases the dropout rate and decreases the recurrence, and also improves the survival after liver transplantation. As against the definition of downstaging therapy, downstaging is the process of applying loco-regional therapy, and nowadays also even immunotherapy, to tumors which are currently outside of the accepted transplant criteria, with the aim of reducing tumor burden to allow transplantation. And the setting is usually in the LDLT setting. The potential advantages are that it makes the patient eligible for liver transplantation, makes the survival almost similar to the best liver transplant criteria, that is Milan's criteria, and it selects the patients with favorable tumor biology. So this diagram shows what is the difference between the bridging therapy and the downstaging therapy. If the patient is beyond transplant criteria and we are bringing down to that within transplant criteria, it is downstaging. And if the waiting time is long, then it is bridging therapy. So the most accepted liver transplant criteria is what has been published by Mazzafero in NEJM. It is called as Milan's criteria, single tumor not more than 5 centimeter or less than 3 or less than 3 nodules, each less than 3 centimeter, in absence of macroscopic vascular invasion. So these Milan's criteria has become the benchmark criteria for deciding on transplantation and also for deciding on downstaging therapy. After Milan criteria, there have been many more criteria which have been published and which are now frequently used. Most common of them is the UCSF criteria, but apart from these two, Milan and UCSF, there are many others like up to 7 to TTV criteria, extended Toronto, Kyoto criteria. So many other expanded criteria are there, but the best survival has been with the Milan criteria and almost similar with the UCSF criteria. And as we keep on expanding the criteria, as we keep on increasing those boundaries, the 5-year survival keeps on decreasing. So the best would be with Milan and the UCSF criteria. So what are the modalities to bring down these tumors which are beyond Milan or UCSF? So the modalities are loco-regional therapy. Commonly used are RFA, TACE, and occasionally SBRT, TARE, and others. And other therapies like resection and sorafenib, and now immunotherapy has become more and more common. So, so this is from the ASLD guidelines. If the tumor is beyond Milan criteria, they recommend that they should be considered for downstaging therapy. And once downstaging therapy is started for any expanded patients, then the success of downstaging can be achieved in about 50% of cases. And with the downstaging, successful downstaging, if these patients are subjected to liver transplantation, the post-liver transplant recurrence is very less, and which is almost similar to what can be achieved if the tumor was initially in the Milan criteria or UCSF criteria. So because this has become the basis of all the downstaging suggestion that because when the patient is chosen for downstaging and he has successful downstaging, then these patients do best, because these are the patients who have good tumor biology, and then they can be selected. So when should we do downstaging? Like I mentioned in my previous presentation, that in our INASL BCLC staging system, we have said that if the patient comes with either Milan criteria or UCSF criteria, he can be taken up for upfront liver transplantation. But if he is beyond the UCSF criteria, it is better to downstage them before taking up for transplantation. This is the UCSF downstaging protocol, which is followed in United States, where they do not downstage every patient. So they have a fixed criteria that they'll downstage only those patients who meet these criteria, and these are called UCSF downstaging protocol. As against in India, what we are following is that we are trying to downstage almost all comers. If the tumor is within the confines of liver, we'll do our best with loco-regional therapy, immunotherapy, SBRT, and see if it can be downstage. But in DDLT setting in US, at least they have some downstaging protocol. For example, they would not, they will choose patients whose lesion is less than 8 centimeter, and similarly absence of vascular invasion, and then there's a certain criteria for successful downstaging. So with downstaging, they'll try to bring it within the UCSF criteria. And if the patient, while waiting after downstaging, he again progresses, then it will be called as failure of downstaging. And if there's invasion of major hepatic vessel or any lymph node, obviously if there's spread, then also it will be called as failure. And the 3-month waiting period is very essential. So once you have downstaged the patient, then you have to wait for 3 months. That is the time to assess the tumor biology. If during these 3 months the patient remains stable, the tumor doesn't expand, then these patients have favorable tumor biology, and these patients are good transplant candidate. But if within 3 months these patients have recurrence, or their tumor becomes larger, or there's AFP again rises and all these things happens, then these are patients who would not do after liver transplantation. So waiting period is one of the very important criteria to decide on success of downstaging criteria. I would now present one of the Indian studies which have used downstaging. This is from the Medanta group. So this is a retrospective study. Out of about more than 2,000 patients they had done for liver transplantation, about 450 were for HCCs. Of them, 405 were studied in this paper. About 50% of them were outside Milan criteria and even outside UCSF criteria. So, so they analyzed 300 patients who were, out of these 300, about 121 were beyond UCSF criteria, and of these 45 of them received downstaging, and in 76 no downstaging was done, and then they were taken up for transplantation. The downstaging therapies they used in their paper was TACE, RFA, or a combination of the two. So this was their Kaplan-Meier of recurrence-free survival. So they identified 3 important factors which predicted recurrence. So one was pre-liver transplantation, AFP more than 100, tumor which were beyond UCSF criteria, and FDG PET avidity. So these 3 important parameters they identify as significant risk factors, and they then subsequently made 3 groups of patients. If the patient has got only none of these significant risk factor or only one risk factor, these were labeled as low risk category, and they would do best, and their recurrence was minimum. If they had 2 of these risk factors, then this is the intermediate group with moderate risk of recurrence, and if they had all 3 of these factors, then it would be highest recurrence of this group. So they recommended, that is what, from this paper only, they recommended that if those patients who are beyond UCSF criteria, you will usually fall in the group of moderate to high risk. So these patients, it would be better to do downstaging first and then taking off for transplantation. Can we downstage patients who have portal vein tumor thrombosis? Again, another paper from the same group. So they had 46 patients. This is again retrospective study. 46 patients who had portal vein tumor thrombosis, and some of them were VP1 to VP3, where they used downstaged. So they had VP1 to VP3, 31 patients, VP1, VP2, and of these 31, they downstaged 13 and did not downstage 18, and they directly took for transplantation. The other group were VP3, 14 patients, where they downstage majority of them, and did transplant without downstaging only 3, and they had only 1 patient with VP4, where obviously they first did downstaging. So their downstaging protocol was for portal vein tumor thrombosis was either SBRT plus TARE or SBRT plus TACE and plus minus ablation. And again, they waited for at least 4 weeks, sometimes 6 to 12 weeks, and then they subsequently took for LDLT. And this was an old paper, so they was given sorafenib. But nowadays, immunotherapy, at least better lenvatinib is being given. So the results of this in this paper, they showed that after downstaging, the recurrence-free survival was almost similar to those patients whom they had transplanted without PVTT. So their 5-year overall survival was up to 57%. So patients with PVTT whom they have downstaged and then successfully downstaged and then took for transplantation, their 5-year survival was so much good, 57%, which could not have been possible with systemic therapy or loco-regional therapy. and even the recurrence-free survival was 51%. So in our INASL guidelines, we mentioned that for the small tumors, the treatment choice would be resection, but if the patient is listed for liver transplantation and if there's some delay in liver transplantation, for very small tumors, bridging therapy is not required, but it can be considered AFP is high. For medium tumor, that means T2 size tumor, resection can be considered if there's no clinical significant portal hypertension. But if there is delay for liver transplantation beyond 6 months, then these patients should be considered for bridging therapy. But in LDLT setting where that liver transplant is immediately available, then these patients would not benefit from any local regional therapy prior to downstaging. But for those patients with beyond Milan within UCSF, again liver transplantation, bridging or downstaging is not recommended. But for beyond UCSF criteria, it is better to do downstaging therapy. And even in selected portal vein tumor thrombosis, downstaging can be done. But waiting period is very important to understand the tumor biology. Thank you for your patience.
Excellent talk, sir. I have one question. In an era of immunotherapy, where we see large tumor being disappeared and lymph nodes being disappeared, would this patient also be considered for as a downstaging and for eligible for liver transplantation?
Yes, many case series and case reports have come that with immunotherapy they have done successful downstaging, and then these patients were taken up for liver transplantation. But for after immunotherapy, again, because when we are giving immunotherapy, there would be increased chances of rejection. So we need at least few weeks of waiting, wash-off period, at least minimum of 1 month, better would be 1 to 2 months. Yes. Yeah, so alpha fetoprotein is one of the most important criteria. If it is beyond 1000, then these patients would do very poorly, and then we should not take for transplant. The studies done from India showed that if it is over 100, this forms the poor poor prognostic criteria for it. So this is one of the criteria. So these patients should be subjected to downstaging.
Yeah, thank you, sir.
So I would like to thank the chairpersons and moderators for this session, and for the next session, thank you. For the next session, which is on liver transplantation for HCC, for whom, when and how, I would like to invite Dr. Chirag and Shah and Dr. Pratim Bhatt and Dr. Shreya Butala as chairperson and Dr. Vaibhav Sutaria as the moderator. And I request the chairperson and moderator to introduce the speaker, Dr. Anand.
Dr. Anand Khakkar has done pioneering work for liver transplantation, and for which he has received B.C. Roy National Award. So he's having one of the largest and vast experience in both deceased donor as well as living donor liver transplantation. So I invite him to enlighten us on the role of liver transplantation for hepatocellular carcinoma. Here, Dr. Anand Khakkar.
Thank you, Dr. Sutaria, and thank you, INASL, for inviting me for this opportunity. INASL. good evening, everybody. Thank you very much for the invitation, and thank you, chairpersons. Dr. Ashish, half my talk you already spoke, so I don't know what I will be speaking now. So I will try to justify this, but let's see. Because when we talk about whom, when, and how, there was a lot of these, selection criteria, downstaging, using various Milan and UCSF and all these other criteria. But anyway, that is all beyond this. This thing is not working. Okay. So, since this is a little story of the evolution of liver transplant, and so in the beginning, when liver transplant was in its infancy and there was not a whole lot of success, some of the patients that were selected early on for liver transplant were those with hepatocellular carcinoma, and it was not very well understood as to who are these patients that would survive. And there were hardly any indications. In fact, hepatitis B, which was the most known prevalent etiology for cirrhosis, even that was being considered as a contraindication because we didn't have very effective antiviral therapy, and even the hepatitis B immunoglobulin was not very well, not easily available. So there were a lot of patients with hepatocellular carcinoma that underwent transplant. And obviously, because we didn't know enough about the biology of these tumors, not that we know too much about it even today, but the selection was very random and not structured in any fashion, and the outcomes were not good. And so there was an initial enthusiasm which was followed by a huge decline, and gradually almost we stopped doing transplants for hepatocellular carcinomas. And then around the early 90s, when Vincent Tommaso, he was a fellow at Pittsburgh, a senior fellow, so to say, very senior, and an alma mater there. So he collected this data about these tumors during his fellowship at Pittsburgh, and the same data was structured, and with Dr. Stas' blessings, he published it after he went back to Milan, and it came to be known as the Milan criteria. And then we saw a gradual increase in the number of HCCs being selected for transplant. So this is how we have gradually learned about the clinical behavior of these tumors in patients with cirrhosis and end-stage liver disease. But 50% of these tumors are unifocal and less than 5 centimeters with no extrahepatic spread. In other words, would fit into the Milan criteria. And not all of them are resectable, mainly because of the background of liver disease. Only 10 to 30% may be resectable. Largely, they would be unresectable. And there was a very high rate of recurrence even after these treatments were attempted, mainly because of the fact that the liver itself had a very carcinogenic milieu, apart from the fact that these viral etiologies also contributed to the carcinogenic process in these patients. So about 30% of these patients would be eligible for a surgical resection or transplant, which would be radical therapies, and then 40 to 50% would fall into the lap of our interventional radiologists, and 20 to 30% would be those patients who would not be eligible for any of these two treatments and would only merit palliative therapies. So this is a list of various non-surgical treatment options which are being practiced, and now immunotherapy has just gotten added to the fag end of this list. So the rationale for doing liver transplants in patients with HCC is that the milieu is carcinogenic. The high rate of multiplication of hepatocytes in this hostile environment, the hepatocytes struggling to proliferate and meet the metabolic demands in these patients with cirrhosis, creates a very carcinogenic milieu, apart from the fact that hepatitis B and C also have carcinogenic properties in themselves. So that results in a very high risk of local recurrence, the fact that these tumors are likely to be multicentric, and the background of chronic liver disease with the fear of landing up in liver insufficiency if you treat them very aggressively with non-surgical therapies, particularly when you can't leave behind adequate functional parenchyma, basically builds up the premise where you justify doing a liver transplant for patients with cirrhosis. Apart from that, there is a lot of enthusiasm, and in what Dr. Ashish said also, early tumors, the recommended treatment is liver resection. Even Milan criteria, tumors within Milan criteria, if you could resect, you should try and resect. But there have been landmark papers done by a pioneering French surgeon called Jean Lovett, And there is a whole school of surgeons as well as hepatologists who would agree that if you talk about an individual patient and what would benefit the patient the most, even for smaller tumors, the long-term survival with liver transplant is superior to that of liver resection because of the risk of recurrence and the fact that these cirrhotic livers have a very carcinogenic milieu. The rationale for doing non-transplant therapies, be it non-transplant surgeries or other forms of conservative management, arises from the fact that we have developed a mindset that we live in a world with fewer livers than are needed. And you try to ration the use of these scarce resources. But if you think from the individual patient's benefits perspective and the fact that we have largely living donor programs in this country, we should have this factored in our thought algorithm that from an individual patient's perspective, doing liver transplant probably offers the best prognosis to these patients with liver tumors. And it has been established time and again by not just Mazzaferro and Milan criteria, but a number of papers that have been published subsequently trying to validate those claims. Now, there are several other classification systems like Dr. Ashish also mentioned, and TNM being the most time-tested tumor node metastasis criteria that we apply for all the other cancers in all the other parts of the body, does not seem to justify the selection criteria for HCCs in patients with cirrhosis, because they do not correlate in terms of the prognosis that it offers following surgery or transplantation, and therefore they have been largely put to disuse. It understages the patient, it understages the disease, and therefore the prognosis in more than 1/3 of these patients, and it does not correlate in terms of the tumor-free survival of patients undergoing liver transplant. So a variety of classifications, again, at the cost of repeating. There are all these systems which have been proposed: Okuda, CLIP, BCLC, QP, and the standard TNM. So largely they have, the fact that you have several systems trying to explain the same disease pattern or same set of patients essentially tells us that we have not arrived at the real truth. And there are several elements that have not been adequately quantified in these various staging and classification systems. The most commonly used ones are the Milan criteria and the UCSF criteria, and the Jean Lovett and the Beck-Staines criteria were popular in Europe for some point in time, but then with the advent of the large volume of data that comes out of UNOS and UKTX, the other European criteria have fallen by the wayside and are not clinically relevant. So this is the landmark paper of Vincenzo Mazzaferro, where he showed that 4 years survival was about 84% in his landmark NEJM paper published in 1986. And based on this, UNOS adopted this criteria for allocation of preferential MELD points to these patients, and that has changed the liver transplant game. We have more patients undergoing transplant for HCCs than for other indications, and therefore we have a lot of data now. For people like us, us as in surgeons at large and Indians in particular, we are out there to push the envelope and expand the boundaries of patients with HCCs in cirrhosis who could be taken up for transplant. And one of the what I would say, one of the guidelines, or rather something that would be used as a benchmark for us to compare our outcomes versus that of a standardized criteria, would be the BCLC criteria. This is the magic number that I believe most of us look for, whether we accept it or not, is that if your treatment or whatever treatment you're offering to your patient affords them a chance of 50% survival at 5 years, then you could justify undertaking that innovation in your treatment approach. And that was derived from the Barcelona Cancer Liver Clinic criteria, which says that if a single tumor of up to 7 centimeters, or if it's a multifocal HCC, not more than 3 nodules, none more than 5 centimeters in size, whether you achieve it outright or through downstaging, would be able to justify, as long as you don't have any vascular invasion or extrahepatic spread. The genesis of expanding the criteria for transplant is that the moment you give the patient time and you try conservative therapies and do not eliminate the disease or remove the tumor, the rate of dropout increases with the increase in tumor size. And this is something that was very intriguing, and during my training times, I was given this project to look at the reasons why you have an increasing dropout rate. In fact, if you look at Francis Yao's UCSF papers and everything, the whole purpose of trying to expand the criteria was to try and reduce the dropout rate from the transplant waiting list because of the growth of these tumor factors. And some of my data from my fellowship days, but it's not really worth spending as much time. I'll come back to the research during the later part of the presentation. So the whole idea is, when you want to decide between what form of therapy would best suit your patient with cirrhosis and a liver tumor, various risk stratification, as has been discussed several times during this evening, is that the standard evaluation criteria, which the child are called Pew score, the MELD score, the sodium MELD score, and then the rate at which the indigocyanine dye is what percentage of it would be excreted from the liver within 15 minutes. In other words, trying to assess the parenchymal functional quality of the liver, as well as recently, patients who are not frankly cirrhotic, you would try to assess the quality of the parenchyma non-invasively using a fibroscan as well. And then obviously we have tools like HVPG and others, including the role of alpha fetoprotein or PIVCA2. And 100, as you just mentioned, is something that we've been using. But generally, if you look at large studies across the world, the bad and good prognosis in terms of denying a patient a primary transplant without downstaging, the number is somewhere around 300, if I'm not mistaken, but I'm open to be corrected there. I mean, obviously, if it goes beyond that, beyond 1,000, there's no doubt about it. But whether you would subject somebody to a downstaging protocol or outright take them primarily for a transplant, a number of 100 would be too conservative. Having said that, it is also true that alpha fetoprotein as a molecule being produced by the parenchyma or the tumor in particular is a function of the state of differentiation. So we have seen very highly undifferentiated or anaplastic tumors having completely normal alpha fetoprotein ratios, and therefore we have not been able to, although you would look at these patients with suspicion, you want to subject them to downstaging, but if the size and the other criteria do not mandate a downstaging, we have not been able to convince these patients or ourselves in subjecting them to downstaging based on a high alpha fetoprotein level alone. And I'm saying this so that it is up for discussion. I would like to know what the rest of us think here today as well. So this is something very interesting, gene analysis following microdissection of the HCCs and identifying those HCC signature genes, and this cumulative fractional allelic loss. So the TNM classification was adopted by a very, very renowned transplant surgeon called Iwa Suzuki in Pittsburgh, and he made what is called a PTNM or Pittsburgh TNM criteria, where he would biopsy these tumors and look for the number of foci where you see a loss of heterozygosity in the genomes of these patients with HCCs, and he used that as a prognostic marker. And the prediction of eventual recurrence and death because of recurrent disease was very high using the number of loci where there was a loss of heterozygosity in identifying these in these identified HCC signature genes. But unfortunately, that could not become a recommended protocol or guideline because it required an invasive procedure in patients with cirrhosis and end-stage liver disease. But the bottom line is that the whole problem is in not knowing this biology, the driving factors. It's not the alpha fetoprotein alone. It's not the size alone. There is no single factor which is able to encompass the driver of prognosis in these patients. So during my training, I was given this topic, and this is something that we published eventually, that there is distinctly a difference in patients who are with vascular invasion, without a vascular invasion, within Milan criteria, outside Milan but within UCSF, or those who are within UCSF alone. And obviously this is the best surrogate that we have, the size criteria. And the reason why these size criteria matters is again the part of what I was asked to study, and that with the increase in the size of these tumors, there are certain histologic features that appear in these tumors, and you start seeing these giant, bizarre tumor cells when you see the size of these tumors increase. Now, this is a change in the biological behavior of these tumors with the increase in size, and this is something that is the closest that I have found, not just during my whatever research study, but during whatever literature that I have reviewed as well. So one of them was these giant bizarre tumor cells. The other ones were, you could see microvascular invasion within the tumor, not necessarily what you see macroscopically in terms of portal venous invasion, but even when you see microscopic tumor invasion within the tumors on histology or on biopsy, as well as the tumor grows, you start to see microsatellitosis. Where is that? So yeah, this is the microsatellitosis. So when you have a large tumor, you see these small satellites start appearing within the tumor. There's a tumor, there's a large element of it, and then there are microscopic satellites which go on to make the entire thing, and you see these microsatellitosis just outside the main capsule of the tumor within the cirrhotic liver. So so these histologic features have also been correlated, documented and correlated consistently in terms of predicting prognosis as well as recurrence of these tumors post resection as well as post transplant. So I think Dr. Sharma went through this the same thing that I had. Which are the patients that you would, once you identify the tumor, you ask yourself whether the patient is a resection candidate or a transplant candidate, and if somebody is a resection candidate, you do the risk prognosis or risk stratification using the standard child record PUG as well as the measures of portal hypertension either by platelet count and varices, or you do HBPG. As well as those who are transplant candidates, you assess the tumor, you assess the severity of the liver disease. Those who have bad prognostic factors, you try and subject them to non-transplant surgeries. Those with the transplant, depending on the size and the AFPs, you downstage, etc. It's just selection process. Ultimately, the same thing that I said. Yao also wanted to help the dropout rate and try and optimize them. Again, we all discussed that fibrolamellar HCCs are great, and you could resect them even if they are large, as long as you allow adequate functional liver volume to be. So this is the crux of the presentation. That you have Milan criteria at the bottom, which is what we all abide by, but we are not happy. We want to do more. So you go to UCSF, and then there are a bunch of criteria. Milan himself modified his criteria somewhere in 2002. He published it along with this metro ticket concept that you spoke about. And then there are these Chinese criteria who nobody wants to believe. Kyoto, yes, but beyond that is the BCLC, so it gets shadowed by BCLC. The last two here, they are the ones that are in a lot of discussion. That if you have a tumor which is outside UCSF, are you justified in transplanting them? Would that afford you a 50% survival at 5 years? And yes, as long as Toronto criteria says any size, any number, but a good histology. Now they biopsy. There's a Gujubai called Dr. Shah who has done landmark work for the Toronto criteria, but they used to extensively biopsy these tumors, which we are not able to in most of our patients. And again, Medanta has, like Sir just mentioned, any size, any number. The standard recommendation is no vascular or extrahepatic spread, but then we know, Dr. Soin talks about downstaging PVTT in a variety of ways. And again, as long as we can afford an expected 5 years survival at 50%, we are all justified in doing these things. So, the bottom line is, where is your compass, in terms of the scientific belief system that you carry, you have learned, and you have grown to practice in your programs, and what has been your experience in those things? So almost everybody among here, whoever does liver transplants, have their own little belief system in where is their comfort zone and how much they would like to, or they would be comfortable in pushing the envelope. This you have already dealt with, Dr. Sharma, adequately. What would be downstaging, what is neoadjuvant, and what would be the role of bridging, so I will not bore you more. And again, there has been Francis Yao, the same guy who published the UCSF criteria, has shown that with the intention to treat analysis, when you downstage the tumor down to the Milan criteria. The what you just said, the outcomes are close to those similar to Milan criteria itself. And again, this is what Vincenzo Mazzaferro again popularized the metro ticket concept. With increasing size, you can transplant more, but then the prognosis also comes down. Again, our benchmark being 50% at 5 years should be what we strive for. But the bottom line is that, who are these patients, and the biology being the key, where is our rudder for identifying the biology in these patients? So along the same line, I have been working for all these 10, 12, 13 years transplanting. This is before I came to Ahmedabad. I've done a lot of transplants. About 120 among those were for HCC, that we transplanted both cadaveric as well as living donors. We have about 24 patients with recurrence. One on histology turned out to be a cholangiohepatoma, not cholangiocarcinoma, but cholangiohepatoma, and had a very early recurrence. 54 of them were within Milan, 25 were within UCSF, and 41 were outside UCSF. And there were 9 patients that we undertook transplants for, knowing fully well that there was invasion within the portal vein. And my sub-analysis of these patients are still underway, and I'm not going to be able to talk in detail about the sub-classification of these various categories. So, but whatever I have concrete data, I didn't want to write about something that is not fully detailed out. So, the 9 patients that we treated for portal vein tumor thrombosis, when I was in Chennai, we used to do cyber knife with Fetouche. We put Fetouche, we will give cyber knife to the portal vein tumor thrombus, as well as try and do tear most of the times. We almost never did TACE for these tumors, because TACE was found to be grossly inadequate when you are dealing with tumors that are more than 3 to 5 centimeters in size. You'd leave behind a lot of viable tumor. So we would try and do tear, sometimes bilateral tear, and subject them to cyber knife with a minimum waiting period of 3 months, and if possible, if the physiology allows, we would wait for 6 months. But by and large, we would always wait for at least 3 months and then transplant the patients on after a repeat metastatic workup if they don't have any other recurrence. And invariably, almost all of them were done using living donors, except the first patient in this category, which we transplanted using a cadaveric donor. The problem was these patients were not listable for cadaveric livers, and the reason, the beautiful story about how we got the first patient done using a cadaver liver was that there was a donor who was supposedly brain dead following viral encephalitis, and nobody wanted those organs. And we used to have a bunch of such no-go patients who would not be transplanted anywhere. So I called this guy because he was somebody who was waiting on this list, and we wanted to see how he does. And he knew he was going to die without it, so he said, whatever you say, do it. And we asked for an extra CSF analysis. So, the intensivist did a lumbar puncture, and when he pulled the piston of the syringe, it drew frank pus from the spinal canal. And I was so happy that it is bacterial. Now it is not viral. So this guy is not going to die. And indeed, that guy lived for 8 years after that and had some funny recurrence somewhere else. But similarly, so out of these 9, we have had 4 long-term survivors. 5 didn't make it. So it's a little less than, but close to 50%. But of late, we are not able to find very enthusiastic candidates to go in this category. But otherwise, we are open to doing SBRT and TARE and subjecting these patients to a transplant with LDLT after at least 3 months of waiting and a repeat metastatic workup. Now, I don't know where in this maze of things we would fit in the immunotherapy, because from whatever I have been able to read and assess, I don't really seem to have a grip yet. It has not come into my mental frame as to what role we would have for this immunotherapy, either as neoadjuvant or as adjuvant. And once the immune repertoire has been upregulated, I don't know what it will take to downregulate it. And we as liver transplant surgeons are not in the habit of using T-cell antibodies. Now, you really roused the T cells of all types. Why T cells, B cells, T cells, all kinds of cells. And then we don't use those, thymoglobulins or CD52 blockers, Campath. We don't use them. I don't know how we will get used to down-regulating those revved up cells. When you said 1 month, I was impressed that you have some number in your mind. I have no number in my mind. I'm not able to come up with that grasp of things. So I'm still struggling there. So yes, liver resection is a good option for small HCCs in compensated cirrhosis. But I hate salvage transplants. We have done like 3 of them, and luckily all of them have survived, but they undergo very stormy courses, both pre-op as well as post-op. So we try and avoid that as much as possible. And again, these are things that we all know. New criteria for LDLT and PVTT with the advanced disease needs to be considered. And what I meant new criteria was mainly in regards to the rising role of immunotherapy. But ultimately, all of us, me, Chawda Sahib, Sutaria Sahib, and a host of other surgeons, eventually, we live in our comfort zones. We will only do what we are convinced about. Data is one thing, but you eventually grow into a zone where you are comfortable, and you can push, but only within your belief systems. So that's all I wanted to say. Thank you very much.
This is excellent talk. I think you pushed the limit for liver transplantation and even taking patients beyond UCCF for liver transplantation. Is there any question from the floor?
My question is regarding post liver transplant immunosuppression in HCC patients. So what is your, what do you follow for these patients?
So we try and introduce the mTOR inhibitors at the end of 1 month post-transplant, and like all of us, we would make sure. See, our steroid induction, we started off with using 1 gram when we came back from the West. And then gradually we kept on cutting down. Now our induction Solumedrol during the aneuphatic phase is 125 milligrams. So we give only 125 on table, and then on post-op day 1 it is 50, 40, 30, 20. At discharge it is 20, and within maximum of 2 months it is off, completely off. It can be faster than that, but never more than 2 months. So we try and keep the steroids at the minimum. Never use any induction antibody, even IL-2 receptor blocker. Even if you have bad kidneys or whatever, you can give late tag, you can do MMF if you can. You don't give them anything also, our patients don't reject for some reason. So we minimize the immunosuppression as steroids first, minimize them. Overall, no antibodies whatsoever. At the end of 1 month, we, particularly all HCCs, we introduce mTOR inhibitors. Earlier it used to be sirolimus, now it's everolimus. Only unfortunate part about everolimus is that everolimus is very bad in terms of giving you aphthous ulcers. So we have to give at least 1 week of Visolone 10 milligrams per day for about a week or 10 days, and that I have seen significantly reduces the incidence of aphthous ulcers in these patients and improves the tolerability. And depending upon how good or bad the kidneys are, we try to keep a lower or higher TAC versus a lower or higher mTOR inhibitor. But mTOR inhibitors, the trough level per nanogram per ml is way more potent than tacrolimus. So when you are using, if your trough target for tacrolimus is about 6, then your combined trough of TAC plus everolimus should be like 4 or 5. So initially we used to treat everolimus like tacrolimus, and we ended up patients developing de novo TB and miliary TB and a lot of infectious complications. It's a very potent immunosuppression. So that is something that we have learned over time. So the combined trough is around 5, not more than 5. Again, there is no MMF once you start everolimus. So that part, that's how we do. Lower TAC, slightly more everolimus, combined trough of TAC trough of 5. This is within the first 1 to 2 months, and that's what we maintain. And then you do the HCC follow-up protocol for these guys.
So I have a question. All of you are here. Why we are not having any extra points for HCC in Gujarat Transplant Committee?
See, actually, I think the whole purpose of evolution of these criteria were to have an outcome of a deceased donor liver transplant which matches for HCC, which matches with other indications. the whole, the criterias were evolved, even the Milan came, so that the patients who are being transplanted for HCC, they have outcome at par with the transplantations being performed for other indications. And when we do liver transplantation, these patients are placed on lifelong immunosuppression. So I will slightly differ, because if somebody is, patient with normal liver parenchyma or no clinically significant portal hypertension, why should we subject that patient to a liver transplantation when patient is amenable to liver resection, ablative liver resection? Why should we subject that patient to a lifelong immunosuppression which has potential significant side effects?
Is this a question or a statement?
No, I'm asking.
Okay. So if you're asking, let me tell you that there is plethora of data. Like I said, you can just write Jean Lovet, Jean and Llovet, and there are several others, but this guy has been the most verbose champion. You can look at the long-term outcomes of patients with cirrhosis who have HCC that have been treated either with a surgical resection or transplant or any other form of conservative management. Like for example, if you talk about TACE, okay, so as something which is less than 3 centimeters in size, you have near complete kill rate, okay, with TACE, with RFA, with microwave ablation, whatever other non-surgical or surgical treatment other than transplant versus transplant. So the outcomes are incomparably superior with transplant than without transplant. So that answers your question. Why should you subject them to immunosuppression? Because they will live longer with transplant. So it's about survival advantage. That is one thing. So see, the thing is, please don't mind me. I'm a little aggressive in my words. So this is nothing personal. But you are questioning the fundamental premise, which has been, deeply pondered, considered, and weighed in terms of the benefits of using a scarce resource, among a large variety of indications and patients. And it was found, data-wise, based on level 1 evidence data, that unless you allow preferential MELD exception points to these patients with HCC, I showed you the drop rate, that Yao's second paper, as well as these patients with HCC, you don't give them a liver in time, they will drop out of the list. So there is a net loss of life versus the risk of immunosuppression. So your question is very right. It's absolutely right. It has a theoretical fundamental, which was the question in the 80s and 90s, and then it has been addressed by clinical experience and data which backed up the process of UNOS applying these MELD exception points. And these MELD exception points, it is not just the first revision. It was first introduced and now it has been second and third time revised. Now it is customized to each and every OPTN, each and every OPO. So see, for example, the US has 9 large regions which are OPO driven. And each OPO, depending upon their organ donation and waiting times, have a different time for obtaining the liver, as per the MELD score. So the OPOs are allowed to adjust the MELD exception points in a way that they justify, or they are able to afford these patients early enough graft within the first 3 months. What I am trying to tell you is that this is data verified facts. You don't start questioning the very fundamental of it.
No. See, why I think even in UNS now, they are not giving MELD exception to HCC patients. HCC patients are being kept on waiting list. They are followed for 6 months. And if the tumor grows aggressively, they are not being given the point. The problem is here we are expecting a 5-year survival of 50%. Whereas when a deceased donor is being given to a patient who is not having HCC and only having decompensated CLD, that patient is likely to have 10-year survival of 50%.
Wrong.
So that is why the MELD exception is...
So this presumption is wrong. This 50% 5-year survival is a benchmark for us when we are pushing the envelope. When you're talking about patients within Milan criteria or within UCSF criteria, you're not talking about 50% 5 years. You're talking about at least 80% 5 years.
But the thing is, at present we don't know that which patients will have low biologically aggressive tumor. That's why there are different criteria which are trying to address, which are trying to pick the patient with having better biology and no microvascular invasion. At present, there are no objective parameters to find out that which patients are having microvascular invasion as well as poorly differentiated tumors. So till the objective parameter comes, we have to rely on the morphology of the tumor, that is the size and number, and the radiology and the AFP and PIVCA. So male exceptions are not being given even in UNRs.
Boss, you are grossly misinformed. I'm sorry to be so blunt. You are grossly misinformed if you are telling me that within Milan criteria, there is no MELD exception points in UNOS. Is that what you're telling me?
Yeah, I'm telling. Because see, the thing is, we are not very sure of the biology of the tumor.
The biology of the tumor we have never known. Because that is where the struggle is. We are trying to identify features which are histological, which is not doable, and therefore the best surrogate. In the absence of histology, the best surrogate is size. And what I showed was that how an increasing size also correlates with a certain aggressiveness in the histological features.
Yes.
And it has been accepted that the morphology, see, everything, life on this planet is subject to evolution, and so everything that we have learned is also subject to evolution. As we learn more, we improve. But until we learn more, we cannot stop working or functioning based on whatever we know. That is how it is. Boss, I am telling you, there is MELD exception points which is customized to the waiting time of each OPO.
Patients will wait on the waiting list, and if the tumor grows beyond the tumor, patient will be kept on the waiting list. They won't be given upfront exception point.
So how much do you wait?
They wait for 6 months.
So within Milan criteria,
then, patient will be on waiting list, and patient will be, the organ will be allocated as per the MELD or sodium MELD. And patient will be given MELD exception 22 points if the tumor is not progressing within 6 months. That is what I know, and I may be incorrect.
You are incorrect.
I will see. But see, the purpose of criteria. Why then? Why should be the criteria? Why we are not doing transplant of everybody? Because I think the Milan criteria came because on histopathology, explant histopathology, it was found that the patients who are having HCCs are not having a good survival. A liver transplant otherwise is having very long survival.
You are mixing up words. Please think what you said. You said that on explant histology, they were found to have poorer survival. How do you say that?
See, the patients who were undergoing liver transplantations, the few of them were surviving longer, like 4 years, 5 years, 10 years. So retrospectively, it was found out that these patients were having underlying hepatocellular carcinoma. And that's why the prospective randomized control trial was designed with 28 patients. The famous Milan criteria, and probably that is how the Milan came. I may be incorrect, but I don't think that we should give a message that organ which can benefit a patient with a benign condition should be given to a patient which is having a higher risk of recurrence within 4 or 5 years of transplant. That is what I want to say. And that is why the MELD exceptions are not being given.
In Gujarat.
Even in UNRs.
No. Sir can answer.
No, I'm not aware whether they I used to think that it's being given.
Dada. Okay, you know, you read. Okay, I have no problem. I was working there, I know, and I still know what is going on. Secondly, talk about other states in India. Okay, talk about Tamil Nadu, talk about Karnataka, Hyderabad.
We leave this MELD exception, but do we agree?
No, we are answering because he asked. Otherwise, I would not have. You said why are we all not?
That is administration
part of it.
No. That question.
He asked the question. Otherwise, I was not going to raise this question only.
No. See, at present we discuss science. This is administration. At present, why they are not being given? Why they are not being given scientifically? That is what I want to answer.
Correct.
And see, we have to give them survival of 4 years survival of 70% is required. 4 years survival of 70% is required.
Where did that number come from?
Milan criteria, the famous Milan
84%.
paper.
Was Milan
That
criteria.
was 80. Yeah.
80. So Milan criteria 4 years 84%. Francis Yao UCSF criteria 5 years 71%.
Yeah, but sir, that was a retrospective cohort study. It was a retrospective observational
Francis
study.
Yao, yes.
Yeah, it was not a prospective randomized controls trial like Milan. So that carries a lesser level of evidence.
Dada. So UCSF criteria has been validated by a very large number of papers, and that is why it has become a recommendation in several other countries as well as in India. If you look at the Liver Transplant Society of India, it has adopted this criteria based on the evidences that have been considered by the Liver Transplant Society of India. So just as the UNOS has accepted the UNOS criteria as Milan criteria, the Liver Transplant Society of India has endorsed UCSF criteria a little more generous than the UNOS criteria. So I am not questioning, I am not trying to pitch you versus Vincento Mazzaferro or you versus LTSI. What I am trying to tell you is that you are questioning the very basic fundamentals of all these organizations that they have misconstrued the fundamentals behind such decision making.
What I want to convey is the thing is we have to, when we subject a patient for liver transplant, why the UCC criteria are not in BCS?
We can continue this debate during the dinner. I think we are late. So
thank you. It was so nice.
You're right.
And yeah, thank you so much.
So this was a very lively debate on MELD exception point. So moving further from transplant to now loco-regional therapy. So our next session is on recent advancements in loco-regional therapy for HCC. And for this, I would like to invite on the stage chairpersons Dr. Radhika Chauhan, Dr. Vatsal Mehta, Dr. Saket Rao, Dr. Divyesh Dadhani, and as moderator, Dr. Akash Patel. And I request the chairperson and moderators to introduce the next speaker, Dr. Rozel Gandhi.
So I would like to request Dr. Rozel Gandhi, who is an intervention radiologist at Shushruth Hospital, to take his session on recent advancements in loco-regional therapy for HCC.
Good evening, everybody. Thank you, INASL, for giving me this opportunity. Thank you, Dr. Ashish sir. Thank you, Dr. Chawda sir. અહીંયા કઈ રીતે દેખાય? So till the time the surgeon debates which patient to transplant, we will downstage or bridge, do something. HCC is a global problem and fifth most common cause. We use child pook score, everybody knows about it, to evaluate the patient of CLD. BCLC classification is most commonly used to classify the tumors and which therapy to be used, ablation, resection, transplant, TACE. Our role comes in early stage where we do ablations, and in intermediate stage we do chemoembolization. Chemoembolization has level 1 evidence. We have TARE since 15 years. Radioembolization, it is a good modality to downstage the tumor. So we'll be talking about my talk is about recent advances. So we know RFA is there since many years. Microwave ablation has come since 2017-18, and there are improvements in the TACE, because TACE was not is a level 1 evidence, but it is not up to the mark. We want to improve it. So there is super selective TACE, there is a DEB TACE, drug eluting bead TACE. TARE also has a survival benefit of maybe 6 months to 2 years. But TARE is now used, we are giving higher doses. We do radiation lobectomy, radiation segmentectomy. where we give up to 300 gray dose in a single segment. So the entire segment atrophies. So we'll talk about this. Then there are up to 7 criterias and all. Ablations, as I mentioned, radio frequency and microwave ablation commonly available. Cryoablation and IRE, irreversible electrophoresis, has started. IRE machine is there in Tata, and cryoablation is also done in few places. In cryoablation, with cold, the tumor is destroyed with the liquid nitrogen, cold, and basically there is ice ball formation instead of the heat, which is there in RF and microwave. Then other is the transcatheter therapy, that is transarterial embolization, the bland embolization. Then there is chemoembolization. Then there is drug-eluting bead embolization, and there is radioembolization. The lowest size of particle is in radioembolization, so it goes deep inside the tumor and causes good amount of necrosis. So we'll start with TACE, transarterial chemoembolization. We inject doxorubicin. So in TACE, it goes predominantly in the liver, but also goes in the entire body. Whereas in drug-eluting bead, it doesn't go anywhere. It stays inside the tumor, and it is slowly released over a period of 15 days. Just a schematic diagram where in the drug-eluting beads, there are 100 to 300 microns. So they go up to the capillary level, but doesn't go into the substance of liver. Whereas in TARE, the embolizing agent goes up to the substance of the liver, and it emits beta rays, and there is good amount of necrosis. As I told, the embolization are 3 types: conventional TACE and drug-eluting bead TACE. And now there is one more, balloon TACE, where the microcatheter has a balloon. So it stops the reflux of the chemotherapeutic agent, and it has to go into the liver, into the tumor only, super selectively. These are the drug-eluting beads, and they are mixed with doxorubicin. They are prepared for the embolization, and then they are injected. Indications of TACE: single lesion less than 5 centimeter, 3 lesions less than 3. These are curative indications where super selectively, if the tumor has been treated, they get necrosed completely, and patient is cured. But most of our TACE are palliative. In the BCLC-B, multicentric lesions, bilobar lesion is a single lesion more than 5 centimeter. This is a super selective TACE. We can see the complete lesion has been necrosed. There is complete necrosis. But in drug-eluting beads and also in the C-TACE routinely, it is palliative. The complete tumor is not necrosed. So how does TACE helps? There is dual supply to the liver. Hepatic artery predominantly supplies the tumor, whereas the normal liver parenchyma is supplied by the artery and the vein both. So that is how TACE helps in causing ischemic necrosis of the tumor. Contraindication to TACE: bilirubin more than 3, child score more than 8, main portal vein invasion. If there are multifocal lesions, more than 75% of the parenchyma involved with disease, extrahepatic disease. As we inject doxorubicin, EF should be less than more than 40%, more than 45%, because there is chance of cardiotoxicity because of the doxorubicin. Few examples: this is a single lesion, super selectively TACE has been done, good embolization and good necrosis. Whereas this is a large lesion, and we can see there is some residual component at the periphery in the left hand side lesion. This is palliative TACE. There is a very large lesion also in the segment 4 and the right lobe of liver, and AFP is also very high, and multiple sessions are required. So this is a perfect example of palliative TACE, where we do TACE every 2 monthly or 3 monthly interval, and inject at different places. Then there are subclassification as mentioned by the previous speakers. Multiple trials of TACE and comparison of bland embolization versus TACE, bland embolization versus TACE versus drug-eluting bead embolization. Drug-eluting bead embolization has more amount of necrosis, less chances of toxicity, whereas TACE has little bit higher amount of toxicity. The survival benefit and the is more or less the same. DEP TACE and the C TACE. You can see the survival benefit is the same, but the tumor necrosis is better in DEP TACE. Chemoembolization is recommended. This is an INASL guidelines is recommended for patients with BCLC-B, multinodular asymptomatic tumor without portal vein invasion or extrahepatic spread. Drug-eluting bead shows similar response rates and then gel form lipidol particles, which is used in conventional TACE. And chemoembolization should not be done in decompensated child C patients or an advanced liver dysfunction or the patient has gross ascites. Advancement in TACE, you all know TACE, but we do sometimes we do TACE under 3D CT planning, where the CT is there in the cath lab, so we can exactly know which artery we are cannulating and whether that artery is supplying the tumor or not, because the cath lab routine angiography is 2D, whereas in, if we do a CT, we get a 3D mapping. So this is a lesion, TACE done once, there is a good lipidol deposition, but there is a small fragment segment where there is a no lipidol deposition. So after, this is MRI, after 6 months we can see there is a growth in that segment, the hanging segment of the lesion, and that is enhancing. So we did TACE. It was supplied by the branches of the gastroduodenal artery. This is the GDA, gastroduodenal artery, and we are super selectively in that segment in the feeder artery, which is going cranially. After confirming with 3D CT that we are in the proper position and not injecting in the bowel, this is embolized lipidol is good deposition of lipidol in the tumor, and this is the CT. The left one, the right one is the angiography image and the left one is the CT image. This is how the CT looks in the cath lab. So this is a CT with good deposition, and we know that the TACE has been done properly. Another similar case, segment right lobe lesion, HBsAg positive, 4 centimeter tumor with a sectoral IHBR dilatation. Sorry. This is IHBR dilatation in the right lobe of liver, and this is the lesion projecting into the, it is invading the portal vein, right side, and also causing compression of the biliary duct. This is the 3D CT picture, this is the video, showing good deposition into the entire, the bright one is the lipidol. This is the if you have any other, similarly here, the cranial coronal image, there is good deposition of lipidol inside the tumor, and this is confirmed with CT, and we can do a good embolization. With this type of embolization, the tumor get necros and we can give good results rather than the conventional TACE, but just a 3D CT planning. To expand the boundaries, this is a 7.5 centimeter lesion in segment 7 and 8. This is the angiographic picture showing large ball of tumor, and this is post embolization. There is good deposition of lipidol. But immediately after embolization, we did a microwave ablation of the tumor. And after microwave ablation at 1 month, this is complete necrosis of the tumor. So TACE plus MVA, microwave ablation, it is recommended up to 5 centimeter, but we expanded it and we did this embolization. This patient was done probably 6 to 7 months back, and still he has good necrosis of the lesion and no residue. Importance of superselective TACE, small lesion in the segment 6 of liver, superselectively cannulated the segment 6 artery, and good deposition of lipidol. There is a portal vein thrombus also. into the right main portal vein, and good deposition of lipidol in the thrombus also. So even TACE, if done super selectively and injected properly in that branch, the lipidol gets deposited in the tumor thrombus also. Another few cases, the hypervascular blush are all tumors, so there are multiple tumors. We know this patient won't do well even with TACE. This is balloon TACE. The catheter is inside the artery, the balloon is inflated, so there is no chance of reflux back of the chemotherapeutic agent. So if chemotherapeutic agent goes super selectively and it is adequately injected, we can really give good results with TACE. This is very good deposition of lipidol, the drug here, the white one. Coming to transarterial radioembolization, that is injection of radioactive particles inside the tumor feeding artery, so higher dose of radiation goes inside the tumor. It started in way back 1965, and phase 2 experience demonstrating safety and efficacy came out in 2008. So it has gone a long way. First approval in human beings 1999, FDA in unresectable HCC. Previously it was done for unresectable HCC as a palliative extent, but now we have started in as a radiation segmentectomy and radiation lobectomy setting. As I mentioned previously, the drug-eluting bead and the conventional TACE, the particles are 100 to 300 microns. So they don't go as distally as the radioembolic agents. In radioembolization, even with portal vein thrombosis, radioembolization doesn't block the artery. They go very distally up to the capillary level and they disintegrate. So it is not a contraindication in patients with portal vein thrombosis. Whereas in chemotherapeutic agent, TACE is contraindicated in main portal vein thrombosis because it blocks the arterioles, distal arterioles. So it can cause decompensation. So it is used in intermediate stage and advanced stage. Difference between TACE and TARE. TACE causes ischemia, TARE doesn't cause. As I mentioned, the bead size are smaller, 20 to 60 microns in TARE. It emits beta rays, and beta rays goes from 2.4 millimeter to 10 millimeter. It has a range, so it causes necrosis of the surrounding tissue. It is very good for downstaging, 58% downstaging rates. Time to progression is 26 months in TARE compared to TACE. Now there are various trials of TARE. How we do the procedure is improving slowly. Just like TACE, it started with routine TACE and then we shifted to super selective TACE, drug-eluting bead TACE, TACE with 3D CT. Similarly in TARE, first they used to give radiation to the entire lobe. Now the super selective TARE, we do TARE, measure the volume of the tumor, measure the volume of the liver segment and give high dose of radiation to that segment only. How does it help? It causes necrosis of the entire segment, atrophy of the entire segment. And TARE done in a generalized way and TARE done in a dosimetry way has improved the downstaging and improved the time to progression. Chances of liver function are less, decompensating are lesser with TARE. So TARE has two kinds of sphere, glass sphere and the resin sphere. Therasphere we get from Canada and resin sphere probably we get from Australia. It emits beta rays and causes cytotoxic destruction of the tumor. So these are initial series. The improvements were not good and it was used as palliative measure for portal vein thrombosis. The large series and the intermediate stage, the survival was equal as TACE. Then Yttrium 90, the legacy study for advanced solitary HCC, ORR was 72%, 3-year OS was 86%. This all came, but then came the dosisphere trial where personalized dosimetry was done in a multi-center open label study. 93 patients were assessed, 56 patients were treated, 20 of 28 patients personalized dosimetry and 10 in the standard had objective response. Resection with curative intent after SIRT was observed in 10 of 28 patients in personalized group, whereas less in the standard group. So personalized dosimetry is very important. We have to see the which artery is supplying, how much gram of the tumor tissue is there, and accordingly we should give high radiation to that segment, and that really helps in downstaging. So conclusion, personalized dosimetry significantly improved the objective response rate with locally advanced HCC, and it is safe. It is better than the entire lobe being treated with the radiation. So the routine trials had less survival, and the personalized one had the double survival. These are the routine trials showing median survival of 8 months, 9 months, and it was this SIRT, this selective internal radiation therapy, that is TER, is combined with sorafenib, is combined with immunotherapy, and to downstage the tumor. This was my case. Did a palliative TER, large light lobe HCC with main right and left portal vein thrombosis on lenvatinib, not improving. This is a large tumor, portal vein thrombosis, FDG avid. This is the angiographic picture. Super selectively cannulate the right hepatic artery, and because the entire right lobe was supplied by with the tumor, so cannulated the right hepatic artery, and TER was done. This is the TER entire assembly where the injection is inside this glass, lead glass, and we inject it. After 3 months, the lesion was 12 centimeters, whereas previously it was 18 centimeters. So TER is the best modality to cause atrophy of the tumor, and it has the best chance. This is a 30% atrophy at 3 months. But again, in this setting, it was palliative. It is also done for HCC, neuroendocrine, colorectal. But now comes the evolution of TER, the recent advances. Radiation lobectomy, radiation segmentectomy. Radiation lobectomy is not as good as portal vein embolization. It takes time. The atrophy of the lobe takes time. It takes 6 months at least for the opposite lobe to increase in size and this lobe to decrease in size. So radiation lobectomy and radiation segmentectomy are the newer things. Radiation lobectomy is used to treat HCC and promote an atrophy-hypertrophy complex, and with the treated lobe atrophies and compensatory hypertrophy of the untreated lobe. This facilitates surgical resection. So it is for downstaging and to increase the FLR. The average radiation dose in lobectomy is less. It is 120 to 150 gray. Or otherwise in radiation segmentectomy, we can go up to 300 grays, 200 grays also, because we are super selectively going in that segment only. FLR is time dependent. There was a percentage FLR hypertrophy of 45% at 9 months and more after TER. So hypertrophy is slower compared to portal vein embolization. This is a 68-year-old male, diabetic, hypertensive, chronic alcohol, and AFP was 213, viral markers negative. This is a lesion, segment 7, planned for TER, super selectively injected, 200 grays in the anterior segmental artery and 140 in the posterior hepatic artery. This is good distribution of the drug inside the tumor, and this is post-TER necrosis and post-TER hyperemic changes in the surrounding segment. This is MRI follow-up, and this is surgery done. This is surgery done, right hepatectomy. So ESMO guidelines has told that SIRT may be considered as a non-standard alternative treatment. So Asian guidelines also say that SIRT as an alternative can be used, and it is used for downstaging. Rationale behind immunotherapy and locorenal therapies: following physical tumor destruction, there is release of high antigen load and trigger of tumor-specific T-cell response. And this helps in good anti-tumor response after, if you combine the both. So there are studies coming up of immunological impact of SIRT with Y90 and the immunotherapy combined. So TACE is workhorse. Super selectively TACE is better, even with 3D CT planning in small tumors. If there is entire right lobe is involved, there is no need of 3D CT. We can do with routine conventional TACE. tear with a personalized dosimetry is better than routine tear, and future may be combination to downstage the tumor. Coming to another aspect, ablation. RF ablation is common, it is known. Now microwave ablation has come. The difference is RF ablation we use pads, and it does coagulative necrosis, whereas there is dielectric injury in the microwave ablation, so less susceptible to heat sink effect. And microwave ablation uses electromagnetic energy of higher megahertz, more than 900. There is heat coagulation by alignment of dipoles. The water molecule is aligns along the electric magnetic field, and it is called dielectric hysteresis. It has faster ablation time, and it gives a better ablation zone. So in a smaller time we can ablate a larger tumor. So what we can do is we can ablate larger than 4 centimeter tumors by doing overlapping ablation also, because of the microwave ablation, because the time is less and the ablation zone is very good. So comparison is it uses electromagnetic energy, whereas in radio frequency ablation it gives frictional heating. So frictional heating cannot help when the portal vein is nearby or the hepatic vein is nearby, whereas in microwave ablation we can ablate these tumors very easily. Contraindication: extrahepatic disease, active infection, lesion more than 5 centimeter or more than 4 lesions. Complex cases, lesion near diaphragm, gallbladder or colon, we do hydrodissection and increase the safe area, increase the distance. And if the lesion is near the hepatic vein or portal vein, we do microwave ablation. If the lesion is near hilum, IRE has been started, irreversible electrophoresis, but that machine is not portable. It is installed in Tata, and they do ablation in the lesions near the hilum. And if the lesion is not visualized on CT or sonography, we encounter this type of cases. What we do is we check how much the distance of the lesion is with the portal vein branch or the hepatic vein branch, and we ablate that area. Cases: 70-year-old male, CLD, Lyrates 5 lesion, planned for RFA. This is the lesion, segment 2, very higher up, and this is our electrode position under ultrasound and CT guidance mix. So these are the prongs, and ablated successfully. Another case, this was the lesion I burnt in 2018, and this is the lesion in November 2022. The new lesion coming up, subdiaphragmatic area, very higher up, around 2-3 centimeter from the IVC, and subdiaphragmatic location. Again, this can be ablated. This is the ultrasound picture of ablation, where the hyperechoic area is seen on heating, and with ultrasound and CT guidance, they can be ablated. This is CT during ablation. We can see our prongs inside the tumor. Sorry, the picture is, and this is the necrosis of the lesion. The necrosed tumor and the track. This is the track which can be seen to prevent seeding and to prevent bleeding. To increase the boundaries, this is an example, right lobe HCC around 5 centimeter, patent portal vein. Bilirubin level was around 2. So we didn't do a TACE, we ablated with microwave ablation. This is the enhancing lesion, segment 6. This is a microwave electrode within the lesion. So overlapping ablation was done to achieve proper necrosis, and this is post-ablation, complete necrosis of the tumor. This patient is still on follow-up, and no recurrence as of now detected. These are the post-ablation CT pictures. So with microwave ablation, with faster ablation times, with good ablation zones, we can really ablate more. This is ultrasound picture, how on ultrasound contrast HCC looks. Sorry again. So we have multiple ways to treat and to downstage and bridge, and so that patient can be shifted for surgery or transplant or resection. Thank you.
Thank you so much for a wonderful talk. Any questions from the audience?
We can't evaluate it. We only come to know during the angiography picture. So if there is shunt, we don't inject. First we embolize the shunt with particles. So once we embolize the shunt, part of the tumor also gets embolized. So the deposition of drug is less in the tumor. So the taste would be partial. The response won't be very good. It's not a contraindication, but the response is not good. You can't get a complete necrosis.
Even it depends upon the types of degrees of shunting. There are 3 degrees of shunting. If you can see the left side of the portal vein, that is the maximum shunting, so you should avoid doing that. In 1 and 2, where you see the main portal vein or a branch portal vein during injection, you can perform the embolization, bland embolization.
For tear, it is a relative contraindication because the shunts, arterioportal or arteriovenous shunts, may deposit the radiation into the lungs or other part of the liver.
So for that we do planning, sir. Planning. Before doing the definitive procedure, we do planning for that the lung shunt fraction. If it is very high, then we should abandon the procedure. And one more question, sir. How do you consider hepatic vein invasion? Portal vein is normal, that is macrovascular invasion, and we should avoid all invasive treatment, or we should go ahead with the TACE or tear?
So if there is segmental right side tumor with right hepatic vein involvement and not going up to the IVC, as a palliative measure, when there is no surgical treatment is going to be done, we can still do TACE.
And what is the preferred modality?
TACE or tear, whatever.
Yeah. TACE or tear, which is a better modality for downstaging. If 7 centimeter lesion is there and patient is for transplant candidate. And
I think tear is any day better if the patient is affording, because tear gives good downstaging and reduction in the size of the tumor.
So I was just reading that guideline, 2023, our guideline. They have included SBRT and tear. That is very good to see. So now that modality will become more popular. So there are some literature also, they have done in very small nodules also with curative intent tear procedure in Western countries where cost is not a prohibitive issue. So 2 centimeter, 3 centimeter lesion, they did the tear with total killing of the tumor, like Sir already told, radiation segmentectomy, and it is a total curative.
We know that you are very enthused and you always ready to cross the boundaries, and we are happy for that for patients also. So we would like to know that in your practice regarding microwave ablation, how do you cross boundaries regarding number of lesions, size of lesions, and frequency of microwave ablations?
I think frequency is just one session. We ablate and around 3 lesions. I've done up to 6 centimeter lesion with single lesion, 6 centimeters overlapping ablation, and up to 3, I think even if the lesions are around 4 centimeter or 3 centimeter, we can do microwave ablation.
So single session only.
In single session.
Total 3.
Yes.
Thank you.
My question, what is the cost difference between usual tear and this radiation segmentation?
It's the same. It's the same. Yeah. Whatever dose you asked, 140 grade, 200 grade, 300 grade, the price is the same.
Rosil, we have discussed this in past. I mean, for when will you not taste patient? Because we have recently seen a couple of patients with large HCC without vascular invasion having TACE procedure and developing post-TACE syndrome, decompensating, developing hyponatremia. So, I mean, we were discussing this. I mean, a couple of our trial patients also had the same issue. So, how to predict when not to taste? I mean, I will also ask the other IR to comment on this issue. When not to taste, that's what I'm asking.
I think as the age increases and the number of years increase.
No, they have a very turbulent course and then they recover, They need IV fluids, they need a lot of support and then they make it. So we have seen it quite a few times and not able to predict when not to taste.
Sir, two things you have mentioned, sir. One is post-embolization syndrome or post-taste syndrome, and the other is liver decompensation. So post-taste syndrome will be.
I mean, these are the patients who are up to B7, not B8. So they are okay. Yes. I mean, they are. Otherwise, we don't do it. So mostly A6, B7, not beyond B7. So they are quite okay. So still they behave odd. So that's the reason. I don't know why.
So, sir, the size of the tumor, the larger the tumor, more will be the post-embolic or post-taste syndrome. So that patient will definitely require IV fluids to excrete out the necrotic material or some supports with NSAIDs or paracetamol to reduce the fever or pain. And, sir, decompensation, as you rightly mentioned, that the amount of liver which is damaged by the tumor, if more than 60% of the liver is involved by the tumor, then we will not go for taste. Also, if the patient is having B7 or B8 maximum sometimes, and in that case also if he is having ascites, then definitely that is a no for taste, or bilirubin more than 2.5 or 3. And sir,
of course these are the contraindications, so we anyway don't tear. Yes, and sir. Also surprisingly hyponatremia, so maybe some tubular injury that we are coming across. We have seen a couple of patients like this, similar problem. And
maybe in large tumors, either we don't do, or if we do, we stage. We do very partial, and we see how the patient reacts. Because after 75 years and maybe 10 centimeter or more tumor, the necrosis burden is too large if we do a proper taste. And the patients are okay before taste, and they are really not okay after taste.
And there are scores also, sir. I don't remember exactly currently, but some INASL guideline, they have given them some score to predict the response of tear and test basically. ALBI score, and there are some comparison also, but there is no score that is superior and absolute that we can use clinically.
Thank you.
Thank you. Thank you, everyone.
Thank you, chairpersons and moderator, and Dr. Rosal Gandhi for that excellent coverage of local regional therapy. Now we come to the systemic therapy part. For this, I would like to invite Dr. Rahul Balgami, Dr. Sandeep Shah, Dr. Tejas Modi, Dr. Akash Shah as chairpersons, and Dr. Roshab Kothari as the moderator for this session. Yeah.
So sir is already there, okay. And sir is the course director, okay. And sir will brief us regarding the systemic therapy in HCC. What are the current and upcoming drugs? So over to you, sir.
Okay. Thank you. Slides, please. So I'll be presenting on systemic therapy. So as I've mentioned before, this is the BCLC staging. Below is the INASL BCLC staging. And the basic concept is that with very early stage, the treatment of choice would be either ablation or resection. In early stage, you will give transplant. In intermediate stage, loco-regional therapy, and in advanced stage, systemic therapy. And now coming up is the combination therapy, where even in intermediate stage or even in early stage after resection, there is a role of systemic therapy. So prior to 2007, the only systemic therapy was available was cytotoxic chemotherapy, doxorubicin, 5-FU, cisplatin, etoposide, but it has a very dismal response rate. But after 2007, the drugs targeting tumor angiogenesis had come. So the first one was sorafenib, and then after 2017, the drugs augmenting immune response have also come. So this is the timeline of HCC therapy, starting with sorafenib era, which was approved in 2008 or 2007-8, and then came a period of about 10 years where none of the drugs, there were multiple drugs that were tried, but none could match the efficacy of sorafenib. So none were approved. Then came lenvatinib with the trial which showed non-inferior to sorafenib, and then subsequently nivolumab, and then more TKI, tyrosine kinase inhibitors, those came. And then came the IM BRAVE study, where atezo-bev has been shown to be even more better than this tyrosine kinase inhibitor. And then tremelimumab and durvalumab and many more are under the pipeline. So there is a dysregulated pathway in HCC with all the pathways like JAK-STAT pathways, growth and TGF beta signaling, WNT catenin pathways, many of them are dysregulated. And so many of these receptors or growth factors like VEGF or PDGF, they get upregulated. And then there is a role of these tyrosine kinase inhibitors like sorafenib, lenvatinib, which act on these receptors, and then these dysregulated pathways are corrected, and then there is some response to HCC. In 2018, the Nobel Prize winners in medicine were these two gentlemen, James Allison and Tasuko Hanzo, for discovering the immunotherapeutic drugs and immune checkpoint inhibitors and how those mechanisms would act and benefit the patients of cancer. So how does this act? So when there is a tumor, there is a T cell which tries to recognize that tumor through MHC, and then this is T cell receptors. So subsequently, only this recognition is not there, then subsequently there are many more molecules are there which then go on to attach to their receptors, and some of these molecules are stimulatory, so that these will stimulate the T cell response, and some of them are inhibitory. So they would inhibit the T cell response. So if they inhibit the T cell response, the T cell will not function and the tumor cell will not kill. But if it is stimulatory or functioning, then T cell will actually kill the tumor. So this is the whole process. So of the inhibitory molecules, there is CTLA4, PD1 and PDL1, which are very much important, and these are known as checkpoints because these are inhibiting the tumor response. These are inhibiting the immune response to the tumor. So these are known as, they are breakpoints or checkpoints. So if we are able to focus on these CTLA and PDL1, and if we are able to stop these checkpoints, then these stimulatory molecules will act and the T cell will actually kill the tumor. So these checkpoint inhibitors, like if we give CTLA4 blockers, PD1 blockers, so this whole thing will be blocked, and so there will be immune response. So, and the tumor will be killed. So the first line chemotherapy now with the emergence of immunotherapy are these three: atizo, bevacizumab, lenvatinib, and sorafenib. Sorafenib for last more than 10 years, lenvatinib for last 5-6 years, and now for last 2 years now this has become the first line immunotherapy. So atizo is a monoclonal antibody. It is PD-L1 blocker. It is an immune checkpoint inhibitor. It is given in a dose of 1200 milligram, and it is combined with bevacizumab, which is again a monoclonal antibody, but it is basically VEGF blocker. It is angiogenesis inhibitor, and these two are combined. So these are given at every 3 weekly, and they are continued indefinitely. So the trial which proved their superiority is known as IM Brave 150 trial, which was published in NEJM in 2020, where more than 500 patients were randomized to sorafenib group or atizo-bev group, which was given every 3 weeks, and these patients were followed till progressive disease or any toxicity. The end point of the trial was overall survival and progression-free survival. So the patients included were of advanced HCC, even they had macrovascular invasion, extrahepatic spread. Even those patients were included, about 30-40 patients, 60% patients. And even those patients who have had prior local therapy for HCC were included. And this is the result. This was found superior to sorafenib. The overall survival as well, the overall survival with sorafenib was 4.3 months in this group, but with atizo-bev it was 6.8 months. So median progression-free survival as well as overall survival both had increased. The quality of life also was better with atizo-bevacizumab as compared to sorafenib, because the adverse effects of sorafenib are, as we all know, are much more, but with atizo-bev they are less common. So this was the trial about atizo-bev. Lenvatinib came into the picture after the REFLECT trial, which was published a few years ago, where it was compared to sorafenib. It was an open label trial, and it showed that it was non-inferior to sorafenib. So similar overall survival as compared to sorafenib, but better progression-free survival and overall response, objective response rate. The sorafenib came to the market with SHARP and Asia Pacific trial, which were published in 2008 and 2009, which had shown, as compared to placebo, that they had increased the survival rate. Adverse effect with lenvatinib and sorafenib are quite common, like hand-foot syndrome, hypertension, anorexia, and all these are there. And in up to 1/3 of patients, they require dose reduction, and in less than 10% of patients, they actually require to stop these drugs. Another immunotherapy combination is durvalumab with tremelimumab, which was compared to sorafenib. It was published last year in NEJM, and this also showed that durvalumab and tremelimumab combination was superior to sorafenib, and if we give durvalumab monotherapy, it was non-inferior to sorafenib. But this is not available. So first line systemic therapy for Indian patients, it is atizo and bevacizumab if the patient is obviously of affording, and if he cannot take this, then either lenvatinib or sorafenib. We have largely replaced sorafenib with lenvatinib now. So basically these two only. So first line would be an atizo-bev followed by lenvatinib. The median overall survival has been gradually increasing over since the time of sorafenib. Now it is much more, up to 18, 19 months we can expect. So this is the algorithm which we have given in the 2023 guidelines. First line systemic therapy, atezolizumab. If he is not taking this one, then either lenvatinib or sorafenib, and these two are still not available in India. If there is some progression after any of these, then there is a second line option. With atezolizumab second line, you can choose any of these: lenvatinib, sorafenib, cabozantinib, dagonafinib. If lenvatinib or sorafenib was given as the first line, then in the second line you can even choose atezolizumab in both these, and otherwise these TKIs also would remain. There's been good Indian experience with the use of atezolizumab. This is a multicentric study published by Dr. Anand, where patients were taken from many centers, including Jaipur and Hyderabad and many other, where it was found that when atezolizumab was given to HCC patients, child A, B, and C. With child C, there was poor response, but with child A and child B patient, at least in up to B7, the response rate was as good as that was shown in the initial trial BRAVE 150. So atezolizumab is a safe and effective in child A and B patients of HCC, and but it should not be used in child C patients. Can we use atezolizumab as adjuvant therapy? So this study, which was published just 2-3 weeks ago, where patients who had underwent resection or ablation and who had high risk of recurrence. So they had identified certain criteria. So those patients who had high risk of recurrence, one group was given atezolizumab and other group were only, they were just observed for any recurrence. And it was found that patients who received atezolizumab, they had better progression-free survival. So with these immunotherapy drugs now, our patients on earlier stages can also be offered, although this adjuvant therapy after ablation and resection is not in guidelines. We need many more studies, but at least after loco-regional therapy, adjuvant therapy is even in INASL guidelines. So that can be offered, and with these combination therapies, we can see better overall survival, which was not possible with the monotherapy a few years ago. So more and more permutations and combination of newer drugs as first and second line drugs are on the horizon. And we would also see some biomarkers guided choice of drugs, like it was mentioned previously that can we do liver biopsy, can we do tumor biopsy and then decide on drugs? That is there. Then there's a role of liquid biopsies, and then role of PD-L1 positive tumors and negative tumors. That all this is coming. And earlier use of systemic therapy in the intermediate as well as in early stage is now coming on the horizon, along with the loco-regional therapy. So in advanced HCC defined by BCLC C stage, the current first line therapy options is atezolizumab, lenvatinib or sorafenib, and these drugs have increased the median overall survival close to 18 months, and in future many novel combination of drugs would be there, which are expected to further increase the survival for even advanced HCC. Thank you. I would be happy to take any questions. Neoadjuvant, I think even the last speaker had shown a huge number of trials are going on, neoadjuvant prior to resection, and so I think within next 2-3 years we'll see a lot of action in that setting also.
Still, actually, response rate to this treatment is not high. Like I am brave 150, also the response rate was 27% only. That 5% CR and 20% was PR. So to use some drug as a neoadjuvant, we want at least response rate beyond 50%, and otherwise, few always will be stable days, but remaining patient will progress while you are giving neoadjuvant treatment. So yet that response rate is not there, so they are not much used in the as neoadjuvants.
Yeah, I agree. But with newer immunotherapy, at least in about 1.5 years ago, we read an article in NEJM that in colorectal cancer, I think rectal cancer, there was a drug which gave a complete response. So that was Dostarlimab.
It's a Dostarlimab drug, but which is used for MSI high patients only, and that is the problem with actually still we both are medical oncologists. So Atezolizumab we are able to use for less than 10 or I would say less than 5% of patients. Most of the patients are on lenvatinib, but still response rate is not as high as the hype is given to the drug. And now what is the new actually which is not covered means we do biopsy for all the patients, and whenever is actually cost is not the issue, and where if target mutation is available and target drug is available, where we try to use target drug, and few mutation actually immunotherapy doesn't work, so there actually we don't use the drug even.
Okay. So as told in MSI high, your response rate with immunotherapy is more than 80%. While here, so that is also a very selected patient, and that data was probably for 10 or 20 patients only.
Yeah, 18 patients, I think that
so
was there. But what I want to say that a lot of progress is going on, and for about after 2007, we have for a long period there were no drugs. Now there's a plethora of drugs.
So for immunotherapy, we want marker. Like there is right now only MSI is the best marker which is available, where he has said that more than 70 to 80% we see the response rate. Otherwise, PDL1 marker we have, but there also we don't see all the patients are responding. PDL1 0% also we have seen the CR. And 80% also there is patient progressed on treatment. So yet we don't have marker for the immunotherapy. Once it's available, then I think it will be the beautiful.
I'm just framing all this because we have talked about the surgery. I am surgeon, so surgery okay, but chemotherapy, local regional therapy. So now we can we put something as a take home that there is a large HCC. With locally advanced HCC, if we put, then which is the best modality to offer that patient? Is it surgery is out of question when it's locally advanced? So is it a TARE, TACE, or chemotherapy, or combination?
So this is exactly what is there in the algorithm, INASL, BCLC algorithm. So for patients for intermediate stage or even in advanced stage, so loco-regional therapy plus the systemic therapy is the option. You can sequence anyway, but at least we have to combine both of these for a better overall response.
But I think if the child sees cirrhotics, then again the systemic therapy would be a
there's a limit. So when child C, there's the only best supportive care, and again if the tumor burden is small and if the patient can afford transplant, that is the only thing. But if tumor burden is also large and child C, then only best supportive care. So the systemic therapy, I think no one will go beyond B7 or a B8 at the most. So child C patients would do very poor. I mean, no one would give systemic therapy. No.
You need not biopsy. But the thing is that now we have NGS for most of the malignancies, and there is a scope that you will find some targeted mutation. Say for example, if you get, it is very unlikely, but if you get a MSI high in HCC, then you are pretty confident of giving. Or similarly, you can get anti-RK where you have some other TKI whose response rate is beyond 60-70%. So in HCC still we don't have so many targeted drugs available or targeted mutations which we have find by doing NGS, but that is something which can be explored because with lenvatinib or atezbev, still the response rate and duration of response is not that great. So that is something which can be explored.
Yeah, so now the people are trying with a molecular classification of HCC based on genetic mutation, TERT mutation, and so many other. And then based on those, and so liquid biopsy as well as biopsy is coming up. Maybe in next couple of years it will be used. Till now, we don't do biopsy. Yes.
Then sometimes the before TACE
response is not
yes
good.
Sir, because
yes.
TACE also becomes little bit difficult. The vascularity of the lesion may be decreased, so the uptake of the drug may be less.
So this will depend whether you are using TKIs or whether you are using immunotherapy. And so after TACE, because there's lot of VEGF so that after TACE, if you give TKIs like sorafenib, lenvatinib, then it has better response. But with immunotherapy, we again have to explore, because then there's a role of all these immune checkpoint inhibitors. So all these permutations and combinations are going on, but once the patient comes to you, so, and if you are seeing that tumor, so first as a gastroenterologist or as the IR person, they would at least like to do something so that at least there's a shrinkage of tumor, and then chemotherapy can be continued, this systemic therapy can be continued beyond. But these have to be explored further.
So mostly it will be done initially only. Day one only it will be decided that local treatment can be given or not. It will not after, mostly after 6 months. So if it's given, then day one it's given, and then systemic treatment will be started.
Yes.
Who should treat? Hepatologist or oncologist?
I
now we have started involving more gastroenterologists and hepatologists. So is that a paradigm shift, or what is the legal aspect? And
I would just ask our medical oncologist colleague, how confident are you managing cirrhosis and complications of liver disease?
No. So most of the time it is along with gastroenterologist, because decompensation, when it happens, it is always a fight whether it is due to disease or whether due to underlying hepatitis B or other. So
it's an industry driven. They are training hepatologists to treat these patients because they understand liver better. So I don't know what is the practice worldwide, because they see more HCC patient, and maybe they have underlying liver cirrhosis. So just
basically it has to be multidisciplinary treatment, because it has to be each case should be discussed in the multidisciplinary, whether he goes for IR, whether medical oncologists only treat, or how to manage side effects and the liver decompensation. It has to be multidisciplinary. Even gastroenterologists.
But I guess the loco-regional treatment is important, which is, like before oncologist, if the hepatologist are being involved, then because many times we see the oncologist used to start with the systemic therapies, but they don't concentrate on a loco-regional. But as Dr. Rosil has mentioned, there is an expanded scope, like even we go certain beyond what is mentioned in the guideline. So if you consider the loco-regional, that it's better to involve hepatologist first.
Yes.
But if we are going towards systemic therapy, then the combining oncologist is better. You brought very important point, which is definitely because
couple of months we see that everybody is interested in this.
Yes, sir.
And more hepatologists are getting involved.
And many times, sir,
just
it's not
to know what is happening.
And many times it's not becomes a multidisciplinary.
Yeah.
Oncologists used to start systemic therapy, and and they neglect sometimes the loco-regional, which I have seen actually in clinical practice. So I think the multidisciplinary, the discussion with the hepatologist is more important when you are treating
because
such patients.
Because a very different type of patients, they decompensate and then the oncologist will not understand what is happening.
Yes, yes.
That's very important.
And they neglect the loco-regional therapy also, that what we have seen actually.
Yeah.
Yes.
Institute to institute. Basically at our institute, we used to see all the HCC cases. Medical oncologists were not involved. Decision was taken by a multidisciplinary team which involves IR, hepatologists and surgeons. No oncologist involved.
I mean, you are talking about ILBS?
AIMS.
No such role proven, and all trials were not out. So at that time, maybe now it is definitely a multidisciplinary team only. Should be there.
Means it has been same. Say initially when for prostate cancer, when there was nothing more than orchidectomy, it was always neurosurgeon used to treat. Then came some hormonal tablets. Again, neurosurgeon was comfortable. Then came chemotherapy. Then every metastatic patient came to medical oncologist. Now then there are some newer hormonal therapies which are better and oral and with very less toxicity, then they are comfortable doing it. So again, immunotherapy, we do a lot of immunotherapy for so many malignancies. And it is reasonably safe molecule, but you see a lot of autoimmune toxicities sometimes. Like you will see a pneumonitis happening or a colitis happening, which maybe in a multidisciplinary team, it would be better or easier to pick up. That is what I feel. So it is always better if you can involve medical ones, and this systemic therapy would get more and more complex with time. You may get some newer molecule, and most of the time, because the hallmarks of cancer would stay same, it would also applicable to some other malignancies, and maybe the medical oncologist would have better exposure and experience to that drugs. But I would agree that most of the patients would require a gastroenterologist or hepatologist along with medical oncologist, because we have seen so many patients who are responding but decompensating, and we are not able to manage them.
Thank you.
Sure. So we end the session. Thank you, sir, for that.
Okay. Thank you, chairpersons and moderators. So we have come to the last session of this evening, and this would be an interesting case discussion. It was to be done by Dr. Shravan Bora, but he could not come due to some emergency. So instead of him, Dr. Apurv would be presenting the case. And for this, I would like to invite the panelists, Dr. Hardik Kotecha, Dr. Kunal Bharadwaj, Dr. Ravi Patel, Dr. Tanmay Vyas. And I would like the panelists to invite the speaker for this session.
So, Apurva bhai can start on behalf of Dr. Shravan Bora, sir.
Yes. So this is a good evening all. Thank you, Dr. Ashish Kumar, for inviting for this lecture. So we are starting with the interesting case of HCC. So this is a 61-year male who was diagnosed with metabolic dysfunction associated steatohepatitis 2 years ago in June 2021 during workup of iron deficiency anemia. So at the time of diagnosis, it was child A without any decompensation, BMI 28, no in comorbidities, he has a diabetes since 6 years and hypothyroidism, non-smoker, no alcoholic use. If you see the primary parameters, hemoglobin 8.1, platelets of 89,000, LFTs, bilirubin normal 0.5, albumin 3.3, normal enzymes, alpha fetoprotein 2 and INR 1.2. On gastroscopy, small esophageal varices, mild portal hypertensive gastropathy, and 1.5 square centimeter antral polyp, which was hyperplastic in nature, which was removed. So at the time of diagnosis in June 2021, workup for iron deficiency anemia was done. Stool routine showed occult blood negative, TTG negative, HB electrophoresis normal. Etiological workup for cirrhosis, viral markers and autoimmune markers were negative with normal ceruloplasmin. Gastroscopy, I have already mentioned, there was a polyp which was ulcerated, removed endoscopically. Also for workup of anemia, colonoscopy and limited enteroscopy was done, which was normal. CECT abdomen was done just to evaluate the small bowel, which was not examined by full enteroscopy, which has shown changes of cirrhosis of liver with mild splenomegaly. There was no ascites, no space occupying lesion or portal vein thrombosis at the time of diagnosis. So from 2021 to presentation 1 month back at our hospital, there was no decompensation in last 2 years. A patient was on oral anti-diabetic medications, lactulose and protein supplements. For surveillance of HCC, patient has undergone ultrasound abdomen in 2022 and twice in this year at peripheral center, which was reported no space occupying lesion in the liver. Alpha fetoprotein was done in 2021 and 2022, but in this year it was not done. As patient does not present it to our institute, it was in follow-up at a peripheral center. So this time, current presentation, patient presented with 1 month symptoms of abdominal distension, pedal edema, anorexia and low-grade fever. On examination, corrected BMI was 25, vitals were normal, there was no pallor or icterus, bilateral pitting edema fit was present, and on abdominal examination, there was a moderate ascites. Liver and spleen was not palpable, systemic examination was normal. HbA1c was well controlled, diabetes is well controlled. Diagnostic ascitic test showed low protein, high sec, no SBP, no atypical cells, but this time alpha fetoprotein was 229. So if we see the chart in the first presentation, sorry, can you just please, is this, just please. Okay. So on first presentation, alpha fetoprotein was 2. On this time presentation, HB 9.7, platelets were 73,000. LFTs were still okay. Bilirubin of 0.9. Enzymes were normal. Albumin was 2.9 this time. With alpha fetoprotein, which was normal in 2021 and 2022, this time came to have 229. And USG abdomen showing no space occupying liver. This was USG abdomen done at peripheral center in July 23, showed cirrhosis of liver changes with splenomegaly without ascites or any SOL. Again, this was repeated at peripheral center in August 2023, which again reported as only cirrhotic changes without any HCC. So at our center, we have done the CECT abdomen in view of increased alpha fetoprotein of 229, which have showed large HCC of 8.8 centimeter with in the right lobe, which has showed, which was very ill-defined actually. That's why it may be missed on USG, which is a very large HCC with partial thrombosis at confluence, which was extending into the left portal vein with mild ascites. These were some, sorry for the images. These were some of the CECT abdomen images. So diagnosis at this point of time was made as a right lobe, single large HCC with partial portal vein thrombosis, BCLC stage C, performance status 0. Metabolic dysfunction associated steatohepatitis related cirrhosis with portal hypertension, child B 8 and male score of 9. Patient has well controlled diabetes mellitus, hypothyroidism and iron deficiency anemia. So for the panelist, you can just answer to the panelist, how the diagnosis of HCC of 8 centimeter was missed on USG? And second question was, is there any advantage of MRI over CT scan for HCC? And any brief of abbreviated MRI? Anyone panelist, please, Dr. Hardik can take a question.
So I think more and more NFLD as we are seeing, ultrasound done for screening is actually a very poor modality. Even since the time in Gangaram, we used to do at least annually a triphasic CT or MR. So
Right.
most of these patients will be obese, and we are doing actually screening to pick up early HCC.
Right.
Even
And
with normal AFP level?
even with normal AFP, I would strongly recommend doing a proper triphasic CT or MR at least once in a year. Because if we want to pick up early HCCs, then ultrasound is a very, very poor modality.
Right.
Whether it is a peripheral center or a good high volume center with a dedicated radiologist who is doing ultrasound, many times early HCCs are very difficult to pick up.
Right. Very well said. Yes, so USG is a not good modality. You can see this sensitivity of imaging modalities which we are using for HCC. So if you see per patient sensitivity of ultrasound, it is 64, CT 76 and MRI 85. So in patients with cirrhosis, USG does not allow detection of more than half of early stage HCC. That may be due to poor acoustic window, because of cirrhosis, maybe body habitus, or maybe liver steatosis.
So one more point regarding MRI. Agreed, many people are favoring MRI, but it is not possible for all patients to breath hold for an MRI. To do a good contrast MR, patient has to do prolonged breath holding. If the patient is obese or the patient has ascites, it is difficult, and in many ways CT is a much better modality, at least for the population in general. For a dedicated center, MRI may be okay, but overall I think CT is a better modality, more convenient for patient also.
I think
Yes, 100%. This is what I think we should do every year. Those patients who have advanced fibrosis or cirrhosis, ultrasound is a very poor modality. I don't know why guidelines are not recommending. I would strongly recommend doing annual triphasic CT for all patients who have cirrhosis.
No,
Or
when
shall
we
we do,
write guidelines, it is for the entire society, for every strata of population.
Right.
So we cannot recommend, because huge populations every 6 months or every 1 year. But for individual patients which are coming to our practice, and if they can afford, I think I'll agree with Hardik. So for individual patients, it can be done, at least annual CT scan can be done, or MRI can be done.
or first CT and then yearly MRI, is it
So either
better?
ways, either CT or MR, but I would recommend
At least cross-sectional
annual proper
imaging.
cross-sectional imaging with
Because CT will be difficult with CKD or some diabetic patient with
So that we have to
marginal
individualize.
creatinine.
That we have to individualize.
Yeah.
And then
but ultrasound per se is very poor modality, especially to pick up early HCC.
And any role of contrast USG?
So that is
For
also
early
that is
lesion.
also not widely available.
Yeah.
If it is available.
one more problem with ultrasound is that,
The contrast agent for ultrasound is also many times not available.
not available.
Right.
So ultrasound when we write ultrasound for whole abdomen, the sonologist is focusing on prostate and other things, and then he misses the liver entirely. At least any SOL is missed.
And
so he has to
that
be
is also,
dedicated.
I think operator dependent.
Yeah, it
procedure.
is definitely ultrasound.
Because reproducing same image repeatedly, it's very difficult for ultrasound.
Yeah,
Both operators will focus on different things, and the sensitivity of pick-upping lesion is also different with experience and with individual.
Yeah, so totally agree. USG, though it is a recommended modality, but misses half of the HCCs. Second thing is abbreviated MRI. This is just, there are certain recent studies on these modalities for HCC. Any radiologist can have some input. Abbreviated MRI for HCC. Any experience? So this is just recent, some of the literature I have gone through, that there are 2 or 3 types of there. where abbreviated MRI, they can use non-contrast as well as contrast enhanced MRI, which is different from routine MRI contrast. So this will take less time and it will pick up early HCC which are missed on USG. So there are certain studies which are coming up as a screening or surveillance for HCC. So question to one of the panelists, how many of you routinely recommend alpha-fetoprotein for surveillance? Because in ASLD guidelines and INASL guidelines, only USG for 6 months is recommended, and with the alpha-fetoprotein plus sonography is better than USG alone in our settings.
Yeah, absolutely. Every 6 monthly AFP is must. In such patient also, those who are having HCC with higher AFP level, those could be definitely picked up. But alone AFP is not sufficient. Alone USG with AFP is also not sufficient. As
Cirrhotic
mentioned or
patient,
discussed.
AFP should be done.
Yeah,
if it is in rising trend, then we can early pick up.
So I think in our context, we can see that combination of sonography plus alpha-fetoprotein, that should be known in Indian settings. So combination of alpha-fetoprotein with a cutoff of 20 with ultrasound abdomen, which has got highest sensitivity, and only less than 5% of HCC will be missed when you combine both. This is the recent Cochrane database in 2021. In these patients, because it has a large HCC, there was a debate whether this should patient undergone TESS, TER, or SBRT. Again, the same discussion what we are hearing since last 2 to 3 hours. What should go first? So in these patients, when we have discussed all the modalities, TER patient was not ready for, so patient was referred to IR and patient has undergone TESS. These are certain images of the TESS. IR radiologist was not much happy after the procedure because it was a partial embolization. He was not a complete response what we expect in TESS in this type of tumor with partial portal vein thrombosis. So post-TESS, the recovery was, fortunately patient does not have any post-embolization syndrome. He was discharged on 5th day of TESS, and at 2 weeks follow-up, good thing is ascites has not reappeared actually after albumin and diuretics.
Patient was a child A before?
This child B8. At the time of diagnosis, first 2021, he was child A. This time presentation, it was child B8, mild ascites, which was controlled with diuretics and albumin. So after 2 weeks of TESS, he was asymptomatic with child status of A and MELD of 9. So still patient is on follow-up for now. We have to see the response after the TESS. So is this a resectable tumor?
No, so much of portal hypertension.
Yes, so yes, it is a clinically significant portal hypertension with beyond UCSF criteria.
Even partial thrombosis.
Right, so this is non-resectable tumor. Okay, agree. So any advantage of combining TKI with TESS or role of SBRT plus TESS in this case? Any panelist can take a question. Dr. Ravi or Kunal?
I don't think any advantage. SBRT can be offered, but TK with TESS.
Okay, so so the debate is already going on whether we should offer post-TESS TKIs can be given or not. So only few studies, retrospective studies are available, which is one of them, lenvatinib plus TESS. So when TESS combined with lenvatinib versus TESS monotherapy, in case of unresectable HCC, it's a retrospective study, 120 patients. Lenvatinib was given orally 3 days after the TESS, and drug was withdrawn 3 days before repeating the on-demand test. So what was shown that the median, although the result of combination showed prolonged overall survival and PFS, but median follow-up was not that large to recommend this treatment. So large scale RCTs are required. Again, sorafenib plus TESS, this is a phase 2 study, tactics trial, so that again patient receives sorafenib for a median of 38.7 weeks as compared to less period of time in earlier combinations. They have shown some good results, good longer progression-free survival as compared to TESS alone. So still we require more RCTs to recommend tests followed by TKIs, mainly lenvatinib or sorafenib. In this type of patients, when we have a child B or child B 7 or 8 patients, intermediate or advanced stage with portal vein thrombosis. In these patients, I think SBRT can be more beneficial because of the portal vein thrombosis. So combination of tests plus SBRT would be a good option, but patient was not willing for either TER or SBRT, so test was offered. So as this patient undergone test, when will you assess the response after the test and which modalities? Dr. Tanmay can take the question.
If you are super fast or want super fast result, then immediately next day non-CT, non-contrast CT scan will give us idea about the distribution of lipiodol, if it is done with lipiodol. Otherwise, 3 to 4 weeks is convention for tests.
Right. So generally 4 to 6 weeks period of time, generally we assess the response either by contrast CT or contrast MRI. Both modalities are okay. And for reporting this recurrence, how patient has responded or not, we have certain classification system like INASL, modified RECIST criteria, and LIRATS. So these are mainly 3 criteria, and this, so this LIRATS system, which is reported as a LR non-viable, equivocal, or viable, depending on what is the response of TESS or TER. Is liver transplant a good option in this case, at present or after downstaging? You can take a question, Tanmay. Yes, Tanmay Hardik.
Again discussed as Dr. Anand Khakkar, it depends on the center and transplant team to take decision. So for example, if patient was subjected for TER and on reassessment after 3 months or 6 months, there is no tumor involving vasculatures and there is good response, then maybe yes, definitely few of the centers might have gone for
downgrading.
So generally, the downstaging here comes. When you do the downstaging with TESS or TER, with or without TKIs, just to see patient will qualify for LT under Milan criteria in case of intermediate stage HCC. And it has shown that if you give loco-regional therapy with TKIs, and if patient downstage within Milan criteria, transplant can be offered and they have a very good survival. 52% of the patients which have shown whose tumors are shrunk after treatment to meet the Milan criteria, they are still alive 10 years after receiving the liver. As compared to those who have a upfront Milan criteria, they have a 61% survival. So some difference in there in the survival, but more than 50% survival in this kind of tumors, even with large tumors, portal vein thrombosis, downstaging can be done. And after that, if patient is fitting in Milan criteria, patient should be offered liver transplant. So this is already discussed by Dr. Ashish Kumar, the modified INASL of BCLC staging, and this is a very good modification, and we should follow the staging for better patient outcomes. Thank you. Test was done, done in last month only, so 4 weeks will be completed, so patient will come for follow-up to see the response. So we are planning CCT, and then depending on the response, we'll plan.
If I'm correct, it's BP4 type 2.
Yes.
So the response to any therapy for downstaging would be very rare, am I right?
Yeah, VP4 would be difficult, although in that study they have done 1 patient, but
yes.
So VP up to VP3 people, I think Dr. Anand has left. Up to VP3 downstaging can be tried, but VP4 would be very difficult for this patient.
Yes, it was VP4.
After downstaging, the
better result with living donor transplantation as far as the recurrence of the tumor is concerned?
So there are two reasons for this.
Yeah.
One is those who are in DDLT program, they automatically get enough waiting time. In LDLT, probably they are not waited enough before subjecting to transplant.
Yes.
One is this, and the other is obviously the better liver volume available. These two things. So behavior is judged better in a DDLT setting.
Yes, yes.
It is judged impartial. In LDLT, it is always slightly partial.
So in 3 to 6 month period, we can see the tumor biology and tumor characteristics. Yes. Yes, yes.
So the recurrence rate with LDLT will always be high.
Right.
One more factor, the liver regeneration, which happens
More after LDLT.
The role of liver regeneration in development at HCC
Right.
has also been cited. We
Right.
are not sure, but it is coming up that may precipitate.
Precipitate. Right.
The stem cell will be same for both. For tumor.
Yeah,
so you are telling about the tumor regeneration?
No, liver regeneration.
Liver regeneration.
The factors
Because in
which
LDLT
acts on
small.
Tumor regeneration. Growth factors.
So that is what.
Yes.
The LDLT patients are having half graft, the liver will regenerate, and then liver regeneration may precipitate recurrence of HCC.
Yeah, yeah. So in DDLT, obviously, there is an advantage.
DLT, there is. Sir, see again, see what has been discussed, that if the tumor is progressing aggressively while awaiting for transplant, you will divert that liver to a patient who is likely to have a recurrence within shorter time. You have said that if patients are transplanted, by bridging them down to Milan criteria, the survival is 61%.
Yes.
And if you transplant them with UCCF criteria,
Yes.
they are having less recurrence-free survival. So
Yes.
that is why I think somebody has told me that it has been confirmed that even in UNOS, they are not giving mailed exception
Yes.
at upfront.
Yeah,
They
it's-
wait for the 6 months. If
Yeah.
a tumor is not progressing, only then the tumor mailed exceptions are
Yes. So
given.
you are right, they have to wait for
I'm
6
not
months.
protecting the
Yeah.
administration or so.
Yeah,
This
yeah.
is the scientific
No,
fact.
this is already there.
So Vaibhav bhai, can we give after 6 months?
Yeah, if the tumor is not progressive. Here the
Yes.
whole question,
So we
whole
are
criteria, everything has come to know the biology of the tumor.
Yes. Okay, any more questions?
Thank you, Dr. Apurva. Thank you, all the panelists. So with this, we have come to end of our session. So at the end, I would like to propose a vote of thanks. So first of all, I would like to thank all of you for staying so late and taking time out from your Saturday evening and spending 4 hours with us. Thanks to all the speakers, chairpersons, moderators, and all the delegates who have come. Second, I would like to thank our event manager, Maisha team, for putting up this in a flawless manner. Third, I would like to thank our academic partners, that is Roche, for supporting the INASL for conducting these meetings. And of course, thanks to INASL society as a whole. So with this, I would like to take adieu, and these proceedings would remain on YouTube, so you can anytime go through it and also circulate to your friends and colleagues. Thank you for being.